Good morning, everybody, and welcome to the New England Dementia Forum for 2021. My name's Jenny Pearson. I'm an Education Officer for the Primary Health Network. Before we go any further, I'd like to acknowledge the traditional custodians of the land that we meet on today and pay respect to elders past, present and emerging. We have a great MC today who's Kevin Rigby, who works for the PHN. He's our Marketing Engagement and Strategy Manager, and some of you might know him from ABC Radio on Saturday mornings. He does a session. Just while we're waiting for a few more people to arrive, I'm just going to play a song that the committee who have organised today thought might get us all in the mood. The theme for today is cooperation.
Dudes and they were out on the street. They were clearing out the empty lot and making it neat. I said, man, is this cool? What you trying to do? They said, making a garden for me and for you. They said, hey man, join us, come on, let's go. Together we can make a pretty garden grow.
I'll dig a hole
and I'll plant a seed,
and we can add the water that'll grow when things need
cooperation. Makes it happen. Working together, dig it. Cooperation makes it happen. Cooperation, working together. Now we friends were on the corner hanging out. I said, hey, you can hang around these garbage cans some other day. They said, man, is this cool? What you trying to do? I said, make a street garden for me and for you. I said, hey, cats, join us. Come on, let's go. We'll all cooperate and make a garden grow. You dig a hole and I'll plant a seed, and we will add the water that'll grow when things need. Cooperation makes it happen. Cooperation, working together. Cooperation makes it happen. Cooperation, working together. Now we watch our garden grow and we come back every day, and the people in our neighborhood come round and say,
hey man, this is cool. Tell us what we can do to keep this pretty garden here for me and for you. We all say, hey, join us, come on, dig the seed. We'll all cooperate and keep our garden green.
You trim the leaves
And you pull the weeds.
and I will add the water that'll grow when things need
Cooperation makes it happen. Cooperation.
Hi, everyone. Sorry about that. It sort of stopped quite abruptly there. So I'll just hand over to Kevin Rigby now, who will look after us for the rest of the day.
Thanks very much for that, Jenny. It did end a little bit abruptly and potentially caused a little bit of confusion amongst late attendees. I notice on the question bar saying, hi, I just joined, do I have an audio issue or are we watching Sesame Street? And the answer for that is absolutely we are, and probably not the first time it'll, or the last time it'll get a run throughout the day. Firstly, I'd like to acknowledge that I'm hosting you all today from the lands of the Kamilaroi people, and also acknowledge the traditional custodians of the various lands on which you all are, and pay respects to elders past, present, and emerging, and also extend that respect to other First Nations people joining us today. Welcome to the New England Dementia Forum with an apt theme of zoom in on dementia, even though we're meeting on the GoTo platform. But look, the GoTo Dementia probably just doesn't have the same ring to it. My name is Kevin Rigby. I'm the Marketing, Engagement and Strategy Manager here at the Primary Health Network, and it is a pleasure to be your MC for today. Thank you for attending. A big hello to any pets that are joining us this morning. The more, the merrier. And in what is probably the catchphrase of the last 18 months, I hope that I am dressed appropriately for proceedings today. In terms of emceeing, I must say I've got quite an easy job, because usually at this time I'd be going through the housekeeping and emergency proceedings. But look, since we're all meeting virtually, not completely necessary. And anyway, in my house, in the event of emergency, I'll be turning left, heading down the hall to the front door, where I'll congregate with my family members. Tea and coffee at my place, also available in the kitchen, although we only have instant. So hopefully your refreshment station has a few more fancier offerings. However, we are online. We do have some ground rules. Most, I'm sure, you're completely aware of, given our mode of working mostly over the past 18 months. If you could just check that your microphone is on mute. And if you do have any questions to ask the presenters throughout the day, you can certainly use the question functionality. Similarly, if you're potentially experiencing any audio or sound issues, hopefully I'm coming through loud and clear. During the day, our very own Ellen Maynell will be monitoring and facilitating the questions throughout the presentations. Also, online events can be a little more draining than face-to-face events, so we've scheduled plenty of short breaks throughout the day to give you a chance to stretch and get those legs moving a little bit. Without further ado, to start proceedings, I'd like to introduce our first speaker, someone who's an NHMRC Early Career Fellow at the Brain and Mind Centre, and also staff specialist, neurologist at Royal Prince Alfred Hospital, where they direct the multidisciplinary memory and cognition clinic. She's a clinician scientist with research focusing on metabolic biomarkers in neurodegeneration, to present on understanding frontotemporal dementia from behaviour to language. Could you please welcome Dr. Rebecca Ahmed?
Thanks, Kevin, for the introduction. So welcome to everyone. It's nice to meet everyone virtually. Really what I wanted to do today was give you an overview of frontotemporal dementia, which is an area that I've been in for about the last 12 years and I find very interesting, and I hope that you do as well. And also give you some ideas to, I guess, better manage your patients and some ideas of what potential treatments there are on the horizon. So what is frontotemporal dementia? Well, it's a less common form of dementia than Alzheimer's disease, but it still makes up about 15% of all cases. It's what we call the second most common cause of young onset dementia, which is dementia that occurs in people less than 65 years. And the peak incidence of frontotemporal dementia is between 50 to 70 years. The diagnosis of it is very challenging. A lot of patients aren't diagnosed for several years because they're often told they're depressed or they just lack motivation from psychiatric reasons. And we know that there are multiple different underlying pathologies in the brain that can present like FTD. Usually survival is about 6 to 11 years from when the symptoms have their onset, but it varies with the different types of frontotemporal dementia. And so if someone has behavioural variant, for example, after they're diagnosed, their survival is a lot shorter, roughly 3 to 4 years. And if they also develop signs of motor neuron disease, then it's much shorter, only 2 years. And I guess the devastating thing about frontotemporal dementia is lots of people in their 50s and 60s still have young children, they're still working, and so it's a devastating diagnosis for the family. So there are 2 different papers that I'll point you towards that go through the diagnostic criteria and the symptoms. And essentially, we classify FTD symptoms based on their main symptoms that they present with. So the most common type is behavioural variant frontotemporal dementia, and then we have the language variants of semantic dementia and progressive non-fluent aphasia, and I'll take you through with videos examples of each of those. We classify the language variants as primary progressive aphasias, and as the diseases progress, often they overlap. And so if you see someone early in their disease, you can quite clearly diagnose them as, for example, behavioural variant FTD. But if you see someone who's 7, 8 years into their illness, often they can overlap. So when we talk about, this is just another figure showing the classification. So we've got the behavioural variant at one end and the language variants at the other. And of the language variants, we've got progressive non-fluent aphasia and semantic dementia. And we do know that patients with FTD can also develop motor neuron disease, whereas patients get wasting of their muscles and also swallowing difficulties. And the main reason that we watch out for that is it significantly decreases the survival time, and patients need different interventions such as speech pathology and respiratory intervention if they also develop motor neuron disease. We also know it gets even more complex that the language variants of FTD can also overlap with some conditions that we associate with Parkinson's disease, such as cortical basal degeneration and progressive supranuclear palsy. And that it all gets very, very complex when you look at the different pathologies that underlie each of these symptoms. So I'll try and take you through it today. So the basic take-home message is there are 3 types of FTD. The behavioural variant, where patients present with changes in their behaviour and personality and have what we call impaired emotion processing. Then semantic dementia, where patients lose the knowledge of and meaning of words and objects. They can also become quite rigid in their choices. And then progressive non-fluent aphasia, where patients develop non-fluent speech and have a loss of grammar. So the first type, behavioural variant FTD, these patients have marked changes in their behaviour and personality. About 50% will present with what we call apathy, which is lack of motivation, and then probably the other 50% will present with what we call disinhibition. So that's, approaching strangers in the street, talking to people, loss of social control. The key feature also is a lot of patients have what we call loss of empathy and the ability to read emotion. So often if their partner's upset about something, they just won't see it. Or if their child is crying about something, they'll just shrug it off and say, well, nothing's wrong. They can also develop strange rituals and obsessions, and also quite prominent changes in appetite and food taste. So they'll often develop a preference for sweet foods. So I've got one patient, for example, who will spend their day eating the soft serve ice creams from McDonald's. They can also become quite rigid in their eating choices, so only eat certain types of foods. And on their neuropsychology testing, they have changes in what we call executive function. So that's the ability to plan and sequence. So the main other sign that they have is reduced insight. So they're not aware of the difficulties that they have. And this often makes it difficult for families to manage them. So this is an example of a patient who has behavioural variant FTD. So she is 66 years old. She had symptoms first onset in 2012, so she became quite withdrawn, but she started approaching strangers in the street and having conversation with them. She spent much of the day, so this was a lady who ran her household, she worked, but then she just wanted to spend the whole day watching NCIS. She also developed a quite prominent sweet tooth. She went on a cruise with her husband and she drank 6 glasses of fruit juice at once. On the Annabrook's cognitive exam, which is a measure we do to measure cognition, she scored 89 out of 100, and her neuropsychology assessment showed problems with executive function, memory impairment, and emotion processing. So this is her video, so we might get Jenny to play the video now. Miranda, how do you think things have gone over the last 12 months since we last saw you?
Good.
Good?
Yeah. Well, everything's really good.
Okay, good.
And all my family are so supportive of me. Now,
And what kind of things do you do to keep busy during the week?
I play Words with Friends, which is Scrabble, and no one can beat me.
Yeah. And do you like to watch TV or read any books or things?
I watch The Bold and the Beautiful at 4:30.
Yeah.
I watch them. I've watched them all my life.
No?
What about the other TV shows?
I watch NCIS.
Yeah. What's happening on NCIS?
That's pretty good.
Okay. And what else?
They're a bit the same, aren't they? They're just the same people, and they're just always seemingly finding the baddies within
The baddies. Yeah, the baddies. They go bang, bang, bang.
Yes. So that's an example of a lady who has behavioural variant FTD, and as you can see, she's quite disinhibited. We might go to the next screen, which hopefully I can show from my computer. And this was an example of her MRI scan, which, as you can see, if we go from the back forward, she's got the back part of her brain is fine, but as we get to the front part of the brain, hopefully you can all see that she's got atrophy of the front part of her brain, and it gets much worse. So these are our temporal lobes here, and these are our frontal lobes. And so grey is brain and black is air. And as you can see, there is atrophy of the brain. So I'll just run that video from beginning to end so you can all see. So that's the classical MRI of someone with behavioural variant frontotemporal dementia. We know that increasingly, particularly in patients with FTD, that there is a strong psychiatric overlap, and about probably 10% of patients with behavioural variant FTD will have an underlying genetic mutation. And the most common mutation is the C9orf72 repeat expansion. And the reason that's, I guess we need to know about that is it causes quite prominent psychiatric features. So a lot of patients can, if they have that mutation, present with psychotic features. And so my kind of take-home message is that if patients for the first time develop psychiatric features in their 50s and 60s, it's very unlikely to be a primary psychiatric condition. It's more likely to be an underlying dementia. And at that stage, they should be assessed by a dementia specialist rather than just being labelled as having a psychiatric illness. So I might stop there and ask, does anyone have any questions about behavioural variant FTD?
There's no questions through at the moment. Thanks, Rebecca.
Great. So now I'm going to move on to the language forms, so semantic dementia and the progressive non-fluent aphasia. And so as I mentioned before, we classify these as primary progressive aphasias. And we know that the ones associated with underlying FTD pathology, so pathology in the front part of the brain, are semantic dementia and progressive non-fluent aphasia. There's another language form called logopenic aphasia, and that, I'm not going to go through that today, as that's associated with underlying Alzheimer's disease pathology. So this is the paper that goes through the diagnostic criteria. And essentially for semantic dementia, the main criteria is that patients have the loss of meaning of words and objects. So these are patients that, for example, their wife might say, oh, can you get the tomato out of the fridge? And they'll say, well, what's a tomato? Or can you get me my credit card? And they may say, what's a credit card? As the disease progresses, they can also develop quite prominent behavioural changes, which in the end can often end up much worse than those with behavioural variant FTD, as they can be quite rigid in their choices and difficult to live with. So Jenny, we might play this video. This is an example of a patient with semantic dementia.
I like to read, but I'm not reading as well as I used to. What I find when I'm looking at is that I'll look at a word and it might say, well, you know, use as an example, I might look at this thing that says world, but I might look at that and say it says word.
Are you aware that some words, even though you can read them aloud, you don't know what they mean?
Yes, that's starting to occur too.
Any practical problems using your hands?
Only the names of tools and things like that.
You can use them all right, but you can't think of their names.
No, that's right.
Okay, so can you think of the names of these? We'll start at this end.
I was going to say I thought it was a dog, but it's not a dog. It's a... it probably is a dog, that one. It could be a dog. See what I mean? These don't stay. That doesn't stay. No, that one doesn't stay either.
I'm going to give you some names of some animals.
All right.
And they won't all be here.
No, that's...
Some of them will be there. How about elephant? Antelope.
That, I think.
Horse.
In actual fact, that could be a horse.
Can you say perimeter?
Perimeter?
Do you know what that means?
It's the distance around the outside of something.
Yeah. Can you say Methodist?
Methodist?
What is that?
Well, it could be a church member.
Can you say artillery?
Artillery?
What is that?
Something for shooting.
Can you say British Royal Artillery?
British Royal Artillery?
Yeah.
Is that used by the British? Used by the British Army?
And can you say chrysanthemum?
Chrysanthemum?
What sort of thing is that?
Yeah, chrysanthemum is a flower.
So as you can see, that patient had the loss of meaning of words and objects. So for example, he called the giraffe was an antelope, and he thought that the zebra was the horse. And for example, he couldn't name what an elephant was. And that's kind of classically what we see with semantic dementia, that people lose the meaning of words. It typically starts with less commonly used words, and then comes for more commonly used words. With the MRI scan for patients with semantic dementia, they have a kind of almost classical sign that we use for diagnosis, and that is atrophy of the anterior temporal lobe. Usually it's the left-hand side, where you can see the arrow in A. There are a group of patients that present with initial atrophy on the right-hand side, which is the slide B, and they tend to have much more prominent behavioural changes and what we call prosopagnosia. So that's where you lose the ability to recognise people's faces. And those patients also have much more prominent memory impairment, they get lost, and as I mentioned, behavioural changes, and they develop the language semantic deficits a bit later. So that's semantic dementia. Does anyone have any questions about that?
Hi, Rebecca. No, you must be filling all the spots for everyone. There's no questions.
Then the next type is progressive non-fluent aphasia. And this is where patients, their speech almost sounds like a stutter. They just can't get the words out properly. And they have what we call agrammatism, which is where, for example, the way I like to ask about it is when you write an email, does it grammatically make sense? And a lot of the patients will say, no, it doesn't make sense, and previously their language was perfect. This is a video of someone with progressive non-fluent aphasia. So Jenny, we might show the video.
Can you repeat a few words for me? Caterpillar. Caterpillar. Okay. What is that? What does that word mean?
Well, that was the in the
where do you get those?
Episode, that they ate the capel, well, the cabbage, maybe. That's awful. Yeah. That's awful. Sure. That's awful.
What about hippopotamus?
What was it?
Hippopotamus.
Oh, that's the happo. That was the we went to Africa. Oh, it's awful.
What do they look like, those ones?
Well, it's really big ones, and it goes down the water, and it comes back in the evening, and sorry.
Are they dangerous?
No. Well, yes, definitely. It's really big, just big with
and
house.
What are they? Do they have horns or tusks or?
Well, they're just a big ones. They got big on the toot.
And do they have a big long tail or a short tail?
A very small one.
Yes.
Very small one.
Yeah.
Yes, and you can see it. You can see it. You can see it.
Yeah.
So as you can see from that patient, he had quite what we call disfluent speech, so it almost sounded like a stutter, and he couldn't get the words out. And that's classically what we see in progressive non-fluent aphasia. Again, there is a classical MRI finding that we see shrinkage of the left perisylvian fissure, which is shown with an arrow here. And that's classically what we see in PNFA. Does anyone have any questions on PNFA?
There's quite a few questions have come through now, Rebecca. One question from Anna McGuinness is, initially in the somatic variant, Is it just the name or words that is lost before the meaning and function?
Usually both about the same time. So usually they'll lose, probably the word meaning goes, the word goes first, but then the meaning goes pretty much after. So you might say to them, they can't name things, but then, you know, you also check their semantic knowledge. So you might say to them, well, you can't name an orange, but what color is an orange usually? And it's variable. Sometimes they'll be able to say, well, it's the orange color. But other times it's gone quite quickly. And I mean, the thing to remember is it's the least common words that go first. So for example, I've got someone who's a horticulturalist and they've lost their plant names last because that's what they kind of were used to dealing with every day, but they've lost the names of animals first. So it's variable on what you kind of use in your language.
Right. Another question. Hi, Rebecca. Thank you for a very informative session. Could you please inform us of some strategies to support a person with language variants of FTD? Thank you, Diane Cross.
Yeah, with language variant, usually there are a couple of speech pathologists that are happy to see people via Zoom so for initial one, and then other speech pathologists can take on the exercises that we give. But usually the best one for semantic dementia that I like to give patients is, for example, getting them to make flashcards with pictures of the words that they've lost and then the name of the word underneath and some features of the word. And often that's good in getting them to practice and try and retrain to kind of learn some of those words back. Very late in PNFA as well, patients can develop problems with saliva and secretions. And so that's why it's always important to have a speech pathologist involved to check their swallowing and things like that.
Right, thank you. And one more from Kate Doyle. Does atrophy of the brain always occur in the early stages of FTD? Do you rely on MRI results for a diagnosis, or do you also rely on the neuropsychological testing and history from the family?
Yeah, so that's a really good question. Sometimes early on, there may not be kind of prominent atrophy on the brain MRI. And so in those cases, we usually say, well, this possibly could be FTD because clinically your history and your neuropsychology assessment suggests that it is FTD, but we keep them under close monitoring to see if the brain atrophy develops. There is a subset of patients that we call behavioural variant FTD phenocopy syndrome, and that usually occurs in patients in their 60s and 70s who have always kind of been a bit on the Asperger spectrum. So they will present with behavioural changes but never develop the brain atrophy and have a much slower progression. And we don't know what is the underlying pathology in that group, but it is well described, and if there's no brain atrophy and we've monitored them for kind of a couple of years and the brain atrophy hasn't appeared, then we wouldn't call them true behavioural variant FTD, we'd call them phenocopy syndrome because they've got the brain atrophy, they've got the clinical picture but they don't have the brain atrophy. The other thing that we sometimes use is very early on, if the MRI doesn't show atrophy, we can do a PET scan, which looks at glucose metabolism in the brain, and often that can be helpful in picking up very early cases.
Okay, great for that. And there's just a few comments about great information and thank you, Rebecca. So.
Okay, thank you. So Matt, what I wanted to do is just tell you about some of the tools that we use in the clinic to help with the diagnosis. So before any patient comes to the clinic, we get them to do the Cambridge Behavioural Inventory. And this is widely available on the internet. If you go to the website, just type in Frontier in the University of Sydney, all of these tests and scales are available for free. But essentially, the Cambridge Behavioural Inventory we give to the carer or family member to complete, because often they don't feel comfortable about talking about the symptoms in front of the patient. And so this gives us kind of a good measure of what behavioural changes are there, how severe they've been, and how much they're kind of concerning the carer. And it covers all the aspects of behavioural changes that we see in FTD. We also don't tend to use the mini mental to assess cognition, as essentially it is only a basic screening tool, and patients with FTD particularly can have a score of 29 and have quite prominent frontal lobe dysfunction. So we tend to use the Addenbrooke's cognitive exam, and if you go to the Frontier website, there is instructions on how you use it. I've been using it via Zoom lately because we're in lockdown in Sydney, and it's quite easy to use, and it measures attention, fluency, memory, and also visuospatial function, and also language, and is a good screening tool that covers all aspects of cognition. So essentially, when we make the diagnosis, we tend to use a combination of approaches: the history, the examination, and also the brain imaging. We're using more and more what we call biomarkers, so the PET scan, and also doing lumbar punctures to look, so we can actually differentiate people with Alzheimer's disease, for example, by doing a lumbar puncture, as we're able to measure the major proteins that cause Alzheimer's disease and then differentiate them from frontotemporal dementia. A question, I thought I'd just go through some things that we get asked a lot. People ask kind of how long is this disease going to go on for, and what kind of things will affect survival. And so this is from a study that we did recently where we looked at 75 of our cases with behavioural variant FTD, and the median survival time from disease onset was about 10 years. And without dependence, it was 8.9 years. And the things that tended to lead to a shorter survival were things like a shorter disease duration, if they had poorer visuospatial function, if they had more prominent behavioural changes, if they were a bit older, and if they had increased atrophy in the anterior cingulate cortex, which is the part of the brain that tends to shrink first in FTD. And these are just some graphs that show the survival time from symptom onset in blue and diagnosis in green. In terms of treatment options, up until about last year, there wasn't much that we could offer patients with FTD apart from symptomatic management. And so I think it's good to be aware of that when we look at the impact on carers of FTD, it's essentially much greater than, for example, patients with Alzheimer's disease. So black is the burden felt by carers, and that may be a combination of the patients being slightly younger and also the kind of prominent behavioural changes and changes in personality that are seen early on. When we look at the treatment options, there isn't much available, so we tend to manage the kind of prominent behavioural changes with atypical antipsychotics. Initially, we'd probably start a selective serotonin reuptake inhibitor, which is a antidepressant that helps manage behavioural changes and manage the care burden. And when you compare that, this is a picture of all the different treatment trials that have existed in Alzheimer's disease. FTD is kind of lagging behind a lot, but there are new initiatives such as the FTD Prevention Initiative, which is essentially bringing together groups from around the world that have an interest in FTD, and this has led to a lot of studies, particularly in genetic FTD, to try and combat the disease. And I thought I'd just take you quickly through the genetics of FTD, which is quite complex, and then talk about some of the treatment trials that we've got up and running. So while most cases of FTD are sporadic, so what we mean by sporadic is that you don't have to have a family history. About 10% of patients do have an abnormal gene that's inherited in an autosomal dominant fashion. So that means if your parent has that gene, you've got a 50% chance that you can inherit that gene. And about 80% of cases of FTD are from 3 genes we call MAPT, granulin, and C9orf. Having said that, we do know as well that about 30 to 40% of patients will have a strong family history, and we never find a gene. So there's probably genes out there that we haven't discovered yet. There are clues that there might be an underlying genetic cause to FTD include that there's a strong family history. So they may give a history that 2 or more of their first-degree relatives, so that's parents, siblings, have either FTD or MND. If there's a combination of frontotemporal dementia and motor neurone disease in the family, and as I mentioned before, if there's unusual symptoms, so if they've got delusions and psychotic features, that might make us suspect that there might be an underlying mutation of the C9orf72 gene. So these are the different genes that we know cause FTD. So as I mentioned, the most common is C9orf, granulin, and MAPT mutation. And by far, this is the incidence that they occur. So by far, the most common is the C9orf72 mutation, and then MAPT and granulin at about 10%. And then there are all these other genes that are much less common. The exciting thing is that there are now 4 clinical trials that are running to treat FTD, particularly those with genetic forms. And if you can imagine, having a genetic form of FTD is devastating for families because a lot of the children have watched or cared for their parents going through the diagnosis and then have the prospect of knowing that they may have the underlying gene. So the first trial is one in gene therapy, and it's quite complex. I'm going to try and simplify it in like 2 minutes, but essentially what this is in patients who have a granulin mutation causing FTD, and what it aims to do is essentially we do a lumbar puncture and we inject some genetic material that we then hope is taken up by the nucleus of the cell and replaces the abnormal gene, and then hopefully either stabilizes or causes some improvement in the patient. And so that trial is being run in Sydney. Then there's a second trial again in patients with the granulin mutation, which acts by a different one. This is called the electro trial. And what that aims to do is patients with a granulin mutation have a deficiency of a substance of a protein called progranulin. And this trial aims to give a drug that essentially simply stops the uptake of progranulin into your cells, so it will increase your progranulin levels and hopefully slow the disease progression. The third trial that we've got running is for patients with any type of behavioural variant FTD, so you don't have to have a genetic mutation. And this is a local trial that's started in Melbourne, but it's also running in Sydney, giving an oral tablet called sodium salinate. And essentially what it aims to do is stop the progression of FTD. The tablet is well tolerated, and essentially they're aiming to look at how it affects brain atrophy patterns and cognitive symptoms. And at the moment we're ready to recruit for this trial, but because of lockdown we can't get anyone in to recruit them. But for this one, which I think would be probably most open to people if you knew that they had behavioural variant FTD, because they don't need to have a genetic mutation. The patients need to be aged over 35 years. They have to be living in the community with a carer or partner who's willing to come along with them for the study. And they have to be able to give consent and willing to have a lumbar puncture and an MRI. Then the fourth trial that we've got running is not a disease-modifying tablet, but again, it's for everyone who's got FTD or semantic dementia, and it aims to look at whether oxytocin, which is known in layperson terms as the love drug, can change behaviour in FTD. And essentially it aims giving people a spray up their nose to see if it can symptomatically modify their behaviour. And that study is running out of Sydney as well. And essentially we know that oxytocin improves social behaviour, emotion processing, and trust. And so the aim of giving people oxytocin is to reverse some of the effects that we see with FTD. So those are the trials that we've got running. So if you've got any questions, you can contact Cassandra, who's our study coordinator in Sydney, and she knows about all 4 studies. If you've got people in Melbourne and Perth, they're running the electro and the salinate trials as well. And so I guess the exciting thing is we do have some more treatments available for FTD, and I might stop now and take some questions if there are any. And if you've got any questions, please feel free to contact me on my email, which is below. Thanks.
Hi, Rebecca. Yes, there's a couple of questions. Susan Ronchi says, many thanks for your presentation. With the behavioural variants underlying psychiatric condition, have these people usually had psychiatric symptoms previously? And is this linked to a particular psychiatric doses or set of symptoms?
Yeah, usually not. So as I said, if people develop psychiatric symptoms for the first time in their 50s and 60s, then it's really unlikely that it is a primary psychiatric condition. In neurology circles, we don't believe that people develop, for example, schizophrenia in their 50s and 60s. It's much more likely to be a neurodegenerative condition or a dementia. The only caveat to that would be sometimes patients who have a family history of FTD and motor neurone disease and have the underlying C9orf72 mutation, they may have people in their family who have, for example, schizophrenia in their 20s and 30s and then can develop FTD later on, and probably that was always FTD because they have the underlying genetic mutation. But if we're just talking about people who don't have a family history, it's really unlikely that they have psychiatric symptoms in their 20s and 30s. It's much more likely they have onset in their 50s and 60s, and then we start looking for a neurodegenerative condition.
Right. And Sophie Bailey asks, is there a typical time that people with MND might develop FTD? I had a client recently who was 2 years diagnosed with MND and FTD was only diagnosed 3 weeks ago. Unfortunately, the reported behavioural changes were put down to marriage troubles by an allied health team member.
Yeah, and that's a common history. So we know that probably about 50% of patients with motor neurone disease have behavioural changes, but often they're not, I guess, systematically looked for. And often, it's thought, well, they've got this devastating diagnosis, they're withdrawn and apathetic because of the diagnosis, rather than it being regarded as a behaviour change. So most commonly the behaviour changes are present from diagnosis, but they can develop throughout the course of the disease, and there can be kind of behavioural changes like apathy and lack of motivation to very kind of disinhibited behaviour. We also notice that a lot of patients with motor neurone disease have quite prominent language problems as well. So often they can initially look like a PNFA and then develop the swallowing difficulties and the other motor changes, and that twigs to us that they've got motor neurone disease.
Great, thanks. Colleen Ma asks, usually how long after diagnosis before these patients are unable to function independently or safely in the community from your experience?
I mean, it's really variable. Usually, it's difficult to give a figure because everyone's different. Everyone has different kind of family supports, but usually probably by about 5 to 6 years, people have difficulty functioning independently in the community. And that's why I guess the NDIS is a good thing, particularly for patients less than 65 in terms of having services and things that can help them. But usually we'd probably say about 5 to 6 years after symptom onset, there would be difficulty functioning independently.
Right. Thank you. Anna McGuinness, do the atypical antipsychotics have any association with development of motor symptoms?
Yeah, so that's a good question. So usually the typical antipsychotics, we tend to see more motor symptoms like Parkinsonism. I usually like to use quetiapine, which is an atypical antipsychotic initially, just because it causes less Parkinson-like symptoms, so less slowing and less physical symptoms. The problem as well is often you're left with this quandary of, do you manage the disinhibition for a little bit of Parkinson symptoms in terms of making everyone's life easy? Often also, as FTD progresses and more of the brain becomes involved, they can develop Parkinson's symptoms as part of the disease itself rather than from just the antipsychotic usage.
Great, thanks. Mariana says, great presentation, thank you. Helen Mills asks the question, are we likely to see more drug use in younger days happening?
Meaning more kind of clinical trials? Yes, definitely. So finally, a lot of the pharmaceutical companies are becoming interested in FTD, and so probably in the next kind of 2 to 4 years, there'll be a lot more kind of clinical trials available for patients, which I think is a good thing, because essentially patients are desperate for a cure, or to at least feel that they've done something to stop the progression.
Right. Tina Frost asks the question, is it only ever MND that is the connection to FTD, or could there be other neurological conditions such as myotonic dystrophy or the like?
So I guess we classify it as the FTD MND spectrum, because we know that there is a similar underlying pathology in FTD and motor neurone disease, but you're right, there are other neurological conditions that can have cognitive and frontal lobe changes. So you can get cognitive changes and frontal lobe changes in myotonic dystrophy. In some of the cerebellar ataxias as well, you can get behavioural changes and cognitive difficulties as well. But usually MND is usually quite easy for neurologists to diagnose because there's classical symptoms. So there was a study done a couple of years ago where they looked at if a neurologist suspected MND, how accurate were they in the diagnosis, and it was well over 90%, because we see the kind of muscle wasting and we see vesiculations and we kind of see that classical pattern, and it's quite easy to diagnose MND when it's present.
Great, thank you. And last question, Steph Anderson asks, hi Rebecca, could you please clarify what you said about people in their 50s to 60s not developing schizophrenia and the caveat re-development of schizophrenia in the 20s? Thanks.
So usually it's very unlikely for patients in their 50s and 60s to develop a primary psychiatric condition for the first time. So if you see someone who you think is schizophrenic in their 50s, they will have had symptoms from their 20s, 30s, and may already have a diagnosis of schizophrenia. If you've got someone for the first time that's presenting to see you in their 50s and 60s with, you know, psychiatric features and cognitive change, that is more likely to be an underlying neurodegenerative condition than a primary psychiatric condition such as schizophrenia. The only caveat is in those patients that have a strong family history of frontotemporal dementia and motor neurone disease, where we suspect there might be an underlying C9orf72 mutation. And those patients and families may have people in their 20s that have schizophrenia, which may be early FTD. We're still trying to work that out. But that would be the only caveat where we would say that schizophrenia can develop in your 20s and be associated with FTD. But I guess the take-home message is people in their 50s and 60s, if they're developing psychiatric symptoms for the first time, it's much more likely to be a dementia neurodegeneration than just a psychiatric condition, if that makes sense.
Great, yes, Steph says, excellent, thank you very much. Another question from Maria. What was the association with Asperger's syndrome, please?
Oh yeah, so that's in patients with this C9orf72 mutation. Well, there's two things. So patients with the C9orf72 mutation, we also know as well, those families have increased number of people with Asperger's syndrome. So that's the C9orf72 mutation. But what I was mentioning was that was in relation to patients who have clinical symptoms and signs of FTD, but don't have shrinkage of the brain on their MRI. And it's one of two possibilities. One is they're very early in the disease, so they over a couple of years they'll develop the brain shrinkage. If they don't develop the brain shrinkage on the MRI, we do know there's a group of patients that we call FTD phenocopy. So to all intents and purposes, clinically and on their neuropsych tests, they look like they've got FTD, but their brain MRI never shrinks. And we think that those, when we go back and look at those patients, we get a strong history that they've been on the Asperger's spectrum all their life. And then for some reason, they get to their 50s and 60s and start to decompensate, and the behavioural changes become more prominent. And so for those patients who look like FTD, but over several years don't develop shrinkage on their brain MRI, we categorize them as having phenocopy syndrome. And there are studies going on to see what the long-term outcome in those patients are, but we think that they probably just kind of grumble along for many years and never really decline, but do have these behavioural changes, but they don't kind of pass away like a normal FTD patient kind of within 10 years of diagnosis.
Great, thanks. That's it. No further questions at this stage.
Great. So I think I'm almost at time. So I guess, does anyone have any other questions? Or I just had a couple more slides on how we can use CSF to help with our diagnosis. I don't know if you want me to go through them, or does anyone have any questions, or we can have an early mark.
There is one more question just come up, Rebecca. It's from Caroline Raywood. For mental health clinicians, do we have any idea what percentage of Schizophreniadx in younger people could be early set dementia?
No. And so I guess I would, those studies haven't been done, but I mean, I think we wouldn't call people who present with, if it's just a kind of person in their 20s with no family history of FTD or MND who has schizophrenia, we would just call it schizophrenia. But if we had someone in their 20s who had, you know, an uncle who had MND, maybe a parent who had FTD or a grandmother who had FTD, then we might go hunting for the C9orf72 mutation. But if it's just a kind of sporadic person with no family history who develops schizophrenia in our 20s, we would call it schizophrenia.
Okay, great. And Sandra is asking, what was the Cambridge Cognitive Assessment again, please?
Yeah, it's called the Cambridge Behavioural Inventory. I'll just go back. And so essentially we give it to carers, we send it out in the post and they complete it before they come to clinic. And essentially what they rate is how often over the prior 6 months they have seen these symptoms and how much it bothers them. So we look at all these aspects like memory, orientation, mood, disinhibition, eating behaviours, sleep, motivation changes. And you can download, if you go to the Frontier website at the University of Sydney, the Cambridge Behavioural Inventory is available, as well as several versions of the Addenbrooke's Cognitive Examination in, I think, about 20 different languages. And also there's some other tests that we use that I haven't gone through today, but things like to look at semantic knowledge as well. There's some tests there, as well that we use for the patients with semantic dementia, and there are instructions on how you can use each of those tests there as well. So they're good resources to know about to use in kind of everyday clinic.
Great. And Helen Mills has a question. Is it noticeable with underdiagnosed Asperger's that they have quite a history with drug use, and even more concerning that we might be seeing very early signs of these changes as they are now in their 30s to 40s?
I mean, I think that if you've got someone who's got a diagnosis of Asperger's, that was made from childhood or in their 20s, I wouldn't classify them as having kind of FTD. It's more the people that present in their kind of 50s and 60s that look like FTD but don't have the brain atrophy on the MRI that we would start to go looking for a diagnosis of Asperger's in earlier life. And often it's never been diagnosed, it's just that they've got those behavioural traits. But usually we tend to see it in their 50s and 60s rather than in their 30s and 40s.
Great, thank you. And Sandra says, thank you for a very informative presentation. Would you mind sending us the link to the Frontier website at UOS?
At University of Sydney? Yeah, that's fine. I can send, Jenny, I can send you the link.
Great, thank you. That'll be good. Thank you. That's it.
Great. Well, I think we're just at time, hopefully. But yeah, if you've got any other questions, please email me, and hopefully the talk was useful.
Thank you very much for that, Rebecca. Absolutely. Look, I think given the comments that we've had through and the leveling of engagement and questions, very, very well presented, very informative, and a really great way to start off the day. So thank you again, Rebecca, for your time this morning.
Okay, thanks very much.
And given the level of questions, thank you very much, Ellen. I'd say you're going to have a busy day with the level of engagement, and a great way to start off with information sharing, and hopefully it continues throughout the day at this New England Dementia Forum. Now, we are going to take a short pause, a little break, so you can get up, stretch your legs. I'm sure Jenny is going to replay the Sesame Street song, which is obviously going to be an earworm throughout the day. If you haven't got it in your head, by the end of the day, I'd say we've failed in our endeavours. So we're going to reconvene at 11 o'clock. If we were in person, I'd have a little bell to ding, but I'm going to take you on your word that you'll be back at your PC or on your laptop at 11, and we'll reconvene for the next presentation.
Cooperation makes it happen. Cooperation, working together. Dig it. Cooperation makes it happen. Cooperation, working together. I saw these crazy dudes and they were out on the street. They were clearing out the empty lot and making it neat. I said, man, is this cool? What you trying to do? They said, making a garden for me and for you. They said, hey man, join us. Come on, let's go. Together we can make a pretty garden grow.
I'll dig a hole,
And I'll plant a seed.
and we can add the water that'll grow when things need.
Cooperation makes it happen. Cooperation, working together. Dig it. Cooperation makes it happen. Cooperation, working together. Now we friends were on the corner hanging out. I said, hey, you can hang around these garbage cans some other day. They said, man, is this cool? What you trying to do? I said, make a street garden for me and for you. I said, hey, cats, join us. Come on, let's go. We'll all cooperate and make a garden grow. You dig a hole, and I'll plant a seed, and we will add the water that'll grow when things
pretty garden, you for me and for you. We all say, hey, join us, come on, dig the scene. We'll all cooperate and keep our garden green.
You trim the leaves,
And you pull the weeds.
and I will add the water that our growing things need.
Cooperation makes it happen. Cooperation, working together, dig it. Cooperation makes it happen. Cooperation, working together, dig it. Cooperation makes it happen. Cooperation, working together, dig it. Cooperation makes it happen. Cooperation, working together. Cooperation makes it happen. Cooperation, working together, dig it. Cooperation makes it happen. Cooperation, working together.
I saw these crazy dudes and they were out on the street. They were clearing out the empty lot and making it neat. I said, man, is this cool? What you trying to do? They said, making a garden for me and for you. They said,
Hey man, join us, come on, let's go. Together we can make a pretty garden grow.
I'll dig a hole,
And I'll plant a seed.
and we can add the water that our growing things need.
Cooperation makes it happen. Cooperation, working together, dig it. Cooperation makes it happen. Cooperation, working together.
now we friends were on the corner hanging out. I said, hey, you can hang around these garbage cans some other day. They said, man, is this cool? What you trying to do? I said, make a street garden for me and for you. I said, hey, cats, join us. Come on, let's go. We'll all cooperate and make a garden grow. You dig a hole, and I'll plant a seed, and we will add the water that all growing things need.
Cooperation makes it happen. Cooperation, working together, dig it. Cooperation makes it happen. Cooperation, working together.
Now we watch our garden grow and we come back every day. And the people in our neighborhood come round and say,
Hey man, this is cool. Tell us what we can do to keep this pretty garden, you for me and for you. We all say, hey, join us, come on, dig the scene. We'll all cooperate and keep our garden green.
You trim the leaves,
And you pull the weeds.
and I will add the water that our growing things need.
Cooperation makes it happen. Cooperation, working together, dig it. Cooperation makes it happen. Cooperation, working together, dig it. Cooperation makes it happen. Cooperation, working together, dig it. Cooperation makes it happen. Cooperation, working together. Cooperation makes it happen. Cooperation, working together, dig it. Cooperation makes it happen. Cooperation, working together.
I saw these crazy dudes and they were out on the street. They were clearing out the empty lot and making it neat. I said, man, is this cool? What you trying to do? They said, making a garden for me and for you. They said,
Hey man, join
us, come on, let's go. Together we can make a pretty garden grow.
I'll dig a hole,
And I'll plant a seed.
and we can add the water that'll grow when things need.
Cooperation makes it happen. Cooperation, working together. Dig it. Cooperation makes it happen. Cooperation, working together. Now we friends were on the corner hanging out. I said, hey, you can hang around these garbage cans some other day. They said, man, is this cool? What you trying to do? I said, make a street garden for me and for you. I said, hey, cats, join us. Come on, let's go. We'll all cooperate and make a garden grow. You dig a hole, and I'll plant a seed, and we will add the water that'll grow when things need. Cooperation makes it happen. Cooperation, working together. Dig it. Cooperation makes it happen. Cooperation, working together. Now we watch our garden grow and we come back every day. And the people in our neighborhood come round and say,
Hey man, this is cool. Tell us what we can do to keep this pretty garden new for me and for you. We all say, hey, join us, come on, dig the seed. We'll all cooperate and keep our garden green.
You trim the leaves,
And you pull the weeds.
and I will add the water that'll grow when things need.
cooperation makes it happen. Cooperation, working together. Dig it. Cooperation makes it happen. Cooperation, working together. Dig it. Cooperation makes it happen. Cooperation, working together. Dig it. Cooperation makes it happen. Cooperation, working together.
Welcome back, everybody, on 11 o'clock at the dot. So I trust you had a short, relaxing break. We will have lunch after this presentation as well. It is my pleasure to introduce our next presenter, a geriatrician practicing at Hornsby Ku-ring-gai Hospital in Northern Sydney, at Bateman's Bay Hospital in Southern New South Wales, and also via video conference to Armidale through HealthWise. She's the Clinical Network Director for the Rehabilitation and Aged Care in Northern Sydney Local Health District, and she holds the current chair in healthcare of older people in the Facility of Medicine and Health at the University of Sydney. I'd like to please welcome to present this morning Professor Susan Currell. Good morning, Susan.
Okay, I think I'm unmuted and ready to go. So thanks for the opportunity to talk to you today. It's always nice to actually be there in Tamworth, but it's been a long time, I think, since I've been there. I was actually video conferencing to Armidale yesterday in my clinic, so I kind of feel like I'm there. So my job this morning is to talk a little around some of the challenges that we face in looking after people with dementia. And so I've sort of titled it, What is my patient trying to tell me? And how we look at managing the difficult behaviours and the psychological symptoms that we see with dementia. And just briefly, my objectives, I want to try and explain what behaviours and psychological symptoms of dementia are, what causes them, what's the basis for non-pharmacological management, because that's what we try and do, how we do the pharmacological management, and just to mention just a little bit on consent, because certainly that's something that's come up a lot lately, particularly through the Royal Commission, and the regulations actually all changed on July the 1st for residential care around how we use psychotropic medication. I guess the use or the management of behaviours and psychological symptoms of dementia has been really topical, and I show these pictures of Terry Reeves because these were shown by his daughter to the Aged Care Royal Commission in 2019. And Terry had gone in, he was an active person, he'd gone into respite care because his wife had gone back to Europe to arrange the funeral of her father there. And he went in for 3 weeks. And you can see him at the start and you can see him after a few days, where he had been both physically restrained but particularly given quite a lot of psychotropic medication. And it made a huge difference to him. And I think those pictures really show what we don't want to do when it comes to managing these sorts of things. The Royal Commission into Aged Care did make some really, really good comments. This is the interim report that was released in October 2019, and it certainly I think raised a lot of eyebrows and talked a lot about substandard care, particularly widespread over prescribing. And I guess the final report, which was released in February this year, or actually the 1st of March, by the time the Prime Minister had read it, there were 148 recommendations, but the ones that particularly I think apply to what we're talking about today, that there be a post-diagnosis dementia pathway organised so that there is actually care for people after the diagnosis. That specialist dementia care units, and I think your closest one is actually Cardiff at Newcastle. These are care units for people who really have very, very challenging behaviours and are difficult to manage in normal residential care or at home or in hospital. Regulation of the use of physical and chemical restraints, and that's certainly underway with changes in regulation on July the 1st this year. And there was also a very interesting recommendation that antipsychotic medication could only be prescribed initially by geriatricians and psychiatrists. Now that hasn't happened because I think we all feel that's a bit over the top, but I think it showed that there needs to be some input from geriatricians and psychiatrists and others, skilled nurse practitioners and CNCs, into how we manage these people. So what are we talking about? And there has been quite a bit of debate about what we call these behaviours. We've had challenging behaviours, we've had behaviours of concern, but from my point of view, let's call a spade a spade. These are behaviours and psychological symptoms that occur related to dementia. And I think that's the best description of them, because that's what they are. So we're talking about symptoms of disturbed perception, so seeing things differently, thought content, and changes in behaviour that frequently occur in patients with dementia. And we know up to 95% of people with dementia will experience some of these, and around 80% of them last up to 18 months. They do come and go, and that's what I say to staff and families. This will pass, and it does eventually, but sometimes we have to do something about it while it's happening. It's interesting because these sorts of behaviours are absolutely an integral part of dementia, but cognition is, memory, thinking is much more studied. We know that symptoms can occur at any time during the disease from the prodromal stages. And looking back, I have seen a number of people who have become anxious or depressed before they got the cognitive symptoms. And that certainly does happen with dementia. We know that if you do have these symptoms, you're more likely to decline functionally, so physically, and obviously there's cognitive decline, and you are more likely to end up in care, to be institutionalised. But I think it's really important to say that these behaviours and symptoms are usually manageable, and can respond quite well to a combination of approaches. And I guess that's what I want to talk about today. What are the actual symptoms? So we're talking about aggression, wandering, restlessness, agitation, sexually disinhibited behaviour, screaming, cursing, what we call inappropriate vocalizations. Hoarding is also one. And then those symptoms of anxiety, depression, hallucinations and delusions, those psychotic symptoms, apathy, withdrawal, irritability, But we're also talking about elation, so people who are really hyper, and we don't see it often, but we do see it occasionally. I guess that's a lovely way to be if you do have dementia. Confabulation, where you're making things up. Perseveration, where you just go over and over and over the same thing again and again. Misidentification, so mistaking someone for someone else. This could also sort of relate to hallucinations. Certainly sundowning is what we see, where symptoms become worse, people become more irritable and agitated in the late afternoon, early evening. There can be eating disorders, overeating or refusing food. Shadowing or stalking is something that really does cause carers a lot of stress when your husband follows you into the toilet, into the shower, because he cannot leave you alone. It can become very difficult. And resistiveness to care, so not wanting the care that, that we are and others are trying to provide. How common is it? Well, there was a study, and it's quite an old one, it's 20 years old, in Sydney nursing homes conducted by Henry Brodati and colleagues. They looked at 647 people in 11 aged care facilities, and you can see aggression was very common, as was anxiety and agitation. Delusions were there. I actually often see more hallucinations, but it's interesting. Delusions were there. Activity disturbances, so people were very, you know, wandering, walking. Mood disturbances, certainly common, so depression. The diurnal disturbance, the sleep-wake disturbances, and I mentioned the hallucinations and resistiveness to care, which can be so difficult for staff. But also for carers at home, when your wife will not have a shower, although she desperately needs one, or doesn't wash her, want her hair washed, or won't change her clothes. A study in the US, which was really, I think it's probably the pivotal study that was done in a county in Utah, and they looked at a lot of people and a lot of symptoms, and you can see that 97% of people with dementia had something. So it's pretty darn common, and it's very unusual to have someone that doesn't have any of these behaviours or symptoms at some stage during the course of their disease. And you can see the depression and apathy were quite high, and anxiety, and the delusions are there again. So people having beliefs that have no factual basis, and I'll give you some examples of that. We know that different types of dementia can have different symptoms, so you're more likely to see depression in vascular dementia, and we certainly know about the hallucinations in dementia with Lewy bodies, the compulsive behaviour, the perseveration, the overeating that you will sometimes see in frontotemporal lobar degeneration, and I believe you've already heard about that today, and certainly delusions in Alzheimer's disease. And if there's pathology in different parts of the brain, that also predicts symptoms, and you can see there, if the frontal area, so that's your starter motor, your executive function area, if that's affected, you can see it's the behavioural disturbances, it's the disinhibition, which can cause us a lot of problems, depression. Interestingly, basal ganglia, so you know, where where Parkinson's can also occur, delusions in the temporal lobe, delusions and hallucinations. And you can see the others, decreased serotonin, causes aggression, anxiety, depression, and of course we give serotonin reuptake inhibitors, so to increase the amount of serotonin as antidepressants. They're the commonest antidepressants used today. And if there's decreased noradrenaline, you see depression, and we do have the dual-acting medications like venlafaxine, which increase both serotonin and adrenaline to try and address that. Why do they happen? This is the million-dollar question, isn't it? We know that these behaviours and symptoms are multifactorial, you know, in etiology, and brain pathology is just part of the cause. You've also got to think about biological factors, so what's happening with them in terms of illness, psychological factors, Were they always a bit suspicious, in which case they're now going to be paranoid? Or were they always a bit careful with money, in which case now they're just going to not spend a thing? Also environmental factors, what's happening around them, what's the environment like, is it nice, is it comfortable, is it familiar? And social factors, including with how the carer and family are involved. It's interesting because Dementia Support Australia, so that's the home of DBMAS, Dementia Behaviour Management Advisory Service, they've found at least 50 different factors contributing to these symptoms. And remember, they have seen well over 50,000 people across Australia with behavioural problems, usually in residential care, but also at home. And they found pain was one of the major factors contributing to this. And I think it behoves us all to always consider pain as a reason for agitation or anxiety or aggression, or any change in behaviour. Always think about, is there some pain? How the carer approaches, I think, is really important, and certainly DBMAS have found that. Over or under stimulation, so how do you get that right? Having enough stimulation to keep people interested and not bored, but not too much, because remember, the brain of a person with dementia is a bit fragile. It doesn't cope with as much as it perhaps used to in terms of input. So we also know memory impairment. I mean, if you can't remember what you've been told, of course you're going to do something wrong. And I think we often forget that saying to someone to sit down for a while, they'll remember that for 5 seconds and then they'll get up again. And it's not like they're being difficult. It's just they've forgotten what you asked them to do. Certainly communication issues, if you're not understanding what someone's saying, and always think, have they got the hearing aids in? That's really important. Frontal impairment, so that ability to make decisions, and when people are bored. And let's face it, if you're sitting all day in the same place, you are going to get bored. We have the clinical practice guidelines for management of dementia, and I just mentioned 2 of them here. The website for these is at the bottom, and I hope you have all accessed these. They're freely available as a PDF if you go to that website. And remember, this presentation will be available for you after the workshop today. But our guidelines say very clearly, recommendation 77, health and aged care staff and carers and family should monitor and address environmental, physical health and psychosocial factors that may increase the likelihood of that person with dementia experiencing distressing symptoms. And I think, it's our job to monitor and address these issues. And we do also talk in the guidelines, recommendation 78 is very much about having a comprehensive assessment at an early opportunity by a professional skilled in symptom assessment and management. And this is what DBMAS do really well. I have a colleague, Brian Draper, who is a semi-retired aged care psychiatrist, and he has 6 rules for management of behavioural and psychological symptoms of dementia, and I really like them. I use them all the time, and I talk about them regularly, and here they are. So Draper's 6 rules. The first one is any new behaviour that develops over hours to days is an acute medical problem unless proven otherwise. If it happens really quickly, it's usually medical. And the most likely cause is delirium, an acute confusional state, and it's most likely due to infection, hypoxia, metabolic disturbances, drugs. The list goes on and on, but any cause of delirium can be a cause of a complete change in behaviour. And if you have dementia, you are 5 times more likely to develop a delirium when you are unwell. His second rule, I think, is really important, and I mentioned it before in terms of pain. Most people get grumpy if they are in pain or discomfort, and I think that's really important to remember. So look for pain, look for constipation. We've just had an amazing recovery of a lady who was severely depressed and confused. She had a mixture of delirium and depression, and it turned out she had been chronically constipated for a long time, and she was not that old. She was in her late 60s. Once we cleared that out, and it took a little while, her whole mood, her memory, everything changed. It was very interesting, and talking to family, it had probably been going on for at least 2 years. Incontinence, immobility, when you can't move, you get stiff and sore. Certainly pressure injuries are something we need to look for. Remember sensory impairment. Remember, make sure someone's got their spectacles on. Have they got their hearing aids in? And I always say, don't forget their teeth if they have false teeth, although that's less and less common these days. If they're hungry or thirsty, are they tied in their chair? Is there physical restraint? Sometimes it's unintentional if they can't get out of the chair. Are they cold? Are they hot? What's going on? What's causing that pain or discomfort? We know that behaviour can reflect how the brain's working, and as I said before, cognitive impairment influences behaviour. If you can't remember what someone's told you, you will ask the same question again and again and drive people mad. But if there's frontal lobe problems, again, apathy, disinhibition, those people that say exactly what they think about someone else in the shops. And I have an older couple who's and the husband, he just finds it so hard because his wife makes quite loud comments about everything from the hair to the dress to the shoes of people elsewhere in the supermarket, and she does it at the top of her voice. At the moment, he can't go shopping with her, and he says it is sheer bliss. He has to leave her at home now. Language deficits. If you don't understand what's being said to you because you're not receiving the speech properly, and we know that the more severe the cognitive impairment, the more you are likely to have these behaviours. So coming on to the fourth rule, the person's behaviour is a way of communication. What are they trying to say to you? If they're aggressive or resistive to care, perhaps they're embarrassed. Perhaps they don't know what you're about to do to them. Perhaps they're scared of what you're going to do to them. Number 5, people react to things they don't like about their environment, and we certainly see that with everybody, with or without dementia these days. Is it a comfortable, pleasant, familiar environment? Is it private? Is it safe? Does it feel that way to the person? Can staff communicate, or are they so busy they just rush past and say, I'll be back, which unfortunately is what we often see. Are there activities that are meaningful and purposeful? And I know with my mother, who's got quite advanced dementia now, and she's in residential care, and the staff give her the table napkins to fold, and she'll fold them again and again. She'll also fold other people's washing, because in the the group home environment she's in, all the washing is done in the actual apartment, as is the cooking. And so there's meaningful, purposeful activities, even for people with quite severe dementia. Can family and friends visit? And goodness knows, we know that's not happening at the moment, even though the Aged Care Quality and Safety Commission, so the complaints unit, the accreditors have said very clearly that organisations should have a Partners in Care program so that people can visit their loved ones. And I certainly can visit my mother for an hour every day because I've done the Partners in Care program, yet she's in a lockdown facility. But there are ways to get around this. Are there problems with other residents interacting? And we do see that where there is aggression between residents. And finally, number 6, is there another mental illness going on? Is there a past history of depression or anxiety or psychosis? We always need to ask that, because that will come out. Okay, so I like to think, how do we summarise management? So it's important to name what's happening. So define the symptom and look at, if you can, why is it happening? When is it happening? Where and with whom? So if it's someone who's really aggressive when they have their shower in the evenings, maybe you try and get someone else to do the shower and do it in the mornings and do it differently. Is it the staff member in particular that's causing problems? What makes it better or worse? I think that's important to look at, you know, how frequently and for how long. And there are lots of scales, but even just drawing up a chart with each day and putting a tick or a cross, so that at least when we look after these sorts of people, these sorts of behaviours in people, we can see a pattern of how they occur. The next thing to say is, does the behaviour require intervention? If the person's asking questions all the time, we learn how to deal with that. That's not causing major issues for the person themselves. If it's causing problems with the staff or the family, then maybe the staff and family have to think about how they manage it. But if there are hallucinations, and we see that quite often, if it's you know, hallucinations of rabbits, for instance, and I've had some patients who talk about the black furry bits on the ends of the ears of floppy-eared rabbits. They can see them so clearly. Those rabbits, imaginary or not, are not causing distress. It's only when, for instance, I had one lady who had 2 imaginary children, and she would walk up and down the street trying to find out who owned those children. And you can imagine someone appeared at your door and said, do these children belong to you? You would find it a little difficult, and that did cause some problems. So it's working out, you know, are the behaviours dangerous or distressing? Certainly look at the physical factors we've already mentioned, and I won't go through those again. And again, remember, is vision, what about hearing? And then the psychosocial factors like care, stress, behaviour, boredom, that's important, and environmental factors. And we know from the research we've done over the last 5 years that the cottage model of care, the small group home model of care, is by far the best for people with dementia. Very clear evidence for that when you compare it with standard institutional care. So where my mother is, there are 12 in the apartment. All the meals are cooked in the apartment. So the smell when you go in late morning of lunch is just amazing. The staff do the cooking, and where they can, residents help. So we know that sort of model of care means better care, less use of psychotropic medications, less presentations to hospital. It's very interesting how important that is. And so we really need to be promoting that model of care. And certainly for me, I don't want to end up anywhere other than in one of the good cottage models of care. And they cost the same. I pay no more for my mother than anyone pays in residential care. Certainly the environmental issues, and I've mentioned that briefly with the cottage model of care, but providing a quiet, calm area, having the person's room very clearly identified. So my mother has a lovely box next to her door with special photos and a bird that a glass bird that my father gave her, and that she always remembers. So she identifies that's her part of the apartment. Certainly concealed doors. We talk about Harry Potter doors where you can't see the door. There's some great examples of that. And making sure people can get outside. Where my mother is, she can go outside onto the very big, broad balcony at any time, day or night. And addressing the behavioural issues, certainly allowing people to walk around. You redirect them as you need it to, but it's their home. And that's what we have to remember, it's their home. Certainly it's important that staff and volunteers interact with people to reduce those feelings of isolation or loneliness, particularly now when we don't have lots of visitors into aged care, and always calling them by their name and providing regular reassurance. When your memory is only 30 seconds, you do need reminding that things are okay, lunch is coming, a cup of tea is coming, that sort of thing. Just to go briefly through the non-pharmacological interventions that are out there. And there's stacks of studies and lots of systematic reviews, but the evidence all is fairly low grade because they're not doing really strong randomized controlled trials, because you can't for some things. And certainly there are differences in how outcomes are measured. But there's certainly, you know, some evidence for physical exercise, keeping people active reduces all sorts of difficult behaviours. It can be walking, dancing, simple exercises, but so important to do. And I think we're all finding that in lockdown now, that physical exercise is really important for our mental health. Music therapy, I think, is certainly underused, but doing individualised playlists, singing, dancing, clapping, even having music in the background is really good. Hand massage and gentle touch, I think, is really important. Simulated presence therapy. This is recording a video from family members, putting it on an iPad, and the person can watch it again and again. Years and years ago, we used to do tape recordings of people as if it was a phone call, and people in residential care would listen to those again and again and again because it was a familiar voice and familiar topics. Certainly these days, with all the technology we've got, we can do that quite easily, and it certainly helps. Having those meaningful, purposeful activities that I mentioned before, folding clothes, peeling veggies, hanging out washing, all those things are really important. Animal-assisted therapy, pet therapy, however you want to call it, certainly improves physical activity, anxiety, dietary intake, and I think having a dog or a cat, but even birds can really, people can watch them, even fish. You know, people will sit in front of an aquarium and watch fish swimming. So it's lovely to have that sort of natural, if you like, activity. And aromatherapy, which is something we do think is important. There's been a randomised trial of Melissa officinalis, that's lemon balm, vervain, and certainly of lavender, and that really did reduce agitation in a cluster randomised trial. And that's something we should think about, that aromatherapy can be important. There is also quite strong evidence for family carer education. So if the person understands, the carer understands, it makes a difference. Occupational therapy involvement, we have what's called the COPE program, care of people in their environment, where the OT talks to the carer about, you know, what can and can't be done, looks at how to improve the environment, how to improve activities, how to teach the carer to respond, you know, that don't keep correcting them, distract them. Just teaching them, they're often quite simple things, but make a huge difference. And professional care and education and training is obviously really, really important. And there is very good evidence for that. Now, I want to give you some examples of how, and these are all true examples from the last probably 18 months, 2 years. Mr. Green, obviously the names are different. As you will see, we have green and white and brown and black. But Mr. Green, 82-year-old man, moderately severe mixed dementia, so Alzheimer's and vascular dementia. He'd been in residential care for 3 years. He hadn't had very much language from the time he came in. He wasn't recognising family, but and he did need assistance with all ADL. So he was basically chair fast, but he would smile and interact with carers. And if he was uncomfortable, he would always call out, "Help me, help me, help me." And the staff could usually see, yes, he was thirsty or uncomfortable or needed repositioning, and they could respond to his needs. But he started calling out constantly, "Help me, help me." The staff thought he might have been in pain, so they gave him some analgesics because he did have a known history of quite significant arthritis. This went on and on for days. He developed some diarrhea. He wasn't eating or drinking much, and he wasn't responding to attention from his family who came to visit or from staff. The GP looked, thinking, oh, look, he's got a urinary tract infection, because that's often what causes that change in behaviour. But his urine was clear. But what the GP noticed was bloating and tenderness. And when he came back 2 days later, he actually did a rectal examination and noted probable fecal impaction. Hence the diarrhea, because you have fecal impaction, but you get diarrhea around the mass of faeces. And so you think you're treating diarrhea when it's actually the opposite. So they stopped the codeine-containing analgesics, gave him lots of fluid, lots of aperients, a Senecot milkshake, which is like dynamite, and he had a couple of enemas, and eventually that impaction cleared and he went back to his usual self. But we really had to think about what was going on because of that clear change in behaviour. This man, who had been in dementia-specific care for 2 years, had a diagnosis of mixed dementia. He became incredibly aggressive towards other staff over a period of just a few weeks, and this is very different to his normal personality. And I actually saw this man. We couldn't work out what was going on. We checked him for UTI. There wasn't a change in medications. Didn't appear to be any source of pain or other source of discomfort because he could walk and talk and eat. He couldn't tell us what was wrong. Anyway, there was a discussion between the care manager, the GP, and this man's daughter. And it came up that 20 years earlier, Mr. Brown had had a long-standing conflict with his next-door neighbour over fence and tree issues, and it was so bad, and they'd gone to court, it was so bad they ended up moving. And the daughter commented that a new resident that was in on respite bore a remarkable resemblance to the neighbour, as well as this new man being quite intrusive and loud in his interactions. And so what the staff did was agree to move that new resident, because he was still on respite, to another part of the facility. And once that move happened, Mr. Brown settled down. As soon as this man was gone from his world, there were no further problems. We were looking at all sorts of medications, what we're going to do. We were looking at moving him, when in actual fact the problem was someone else. But you've got to look for what the cause was. And we were just very lucky that the daughter remembered the next door neighbour, because it had been such a drama in their lives. This lady, relatively young, 74-year-old lady in residential care, who had, after moving in, she'd been quite withdrawn and depressed. Antidepressants, several different ones, made very little difference. The facility started a music therapy program with all the residents getting iPods with individualised playlists, and Mrs. Smith initially totally refused to wear them. But the staff kept trying and trying, and over a few days of music, 2 hours, morning and afternoon, she became more interactive and smiling, and then one day she actually began to hum along to what she was listening to and became so much happier, was smiling. And the improvements persisted now for 18 months. She was on her second iPod at the beginning of this year. I'm not sure if she's on her third now, but it really did make a huge difference, having familiar music. This lady, oh yes, this lady was very difficult. In late 70s, she had a history of dementia, but she actually wasn't too bad. She lived with her daughter, and the family and the neighbours found that her constant complaining was really hard to live with. She was the original whinger. And as her care needs increased, they got an ACAT review and moved her to residential care. She was just as unpleasant in residential care, and she was constantly making rude and unpleasant comments. And eventually she was pushed over by one of the residents who was sick of her comments. And Mrs. Black ended up with a fractured wrist and ended up in hospital. And this is a very short version of quite a long period of time. And she continued to be nasty and unpleasant. MMSE was 16 out of 30. Yeah, her memory, orientation and attention were bad, but generally she could still walk and talk. She had no insight into her behaviour. The hospital staff tried distraction. The OT made suggestions. The psychologist came and saw her. The facility didn't want her back, but of course they had to take her back because she was a permanent resident and had tenure. But the staff in the hospital noticed that she would sit and watch the ward budgie for hours. So on return to her facility, the daughter bought a budgie, and she was allowed to keep it in her room, and the staff helped. And the staff also put a bird feeder outside her balcony, and that brought in local birds. And this lady's behaviour did improve. She reduced her nasty comments by at least half. And as far as I know, she's still going with the bird. Obviously, as her dementia progresses, this will change, and hopefully that behaviour will go. But it is very difficult to deal with someone who is just extremely unpleasant. And let's face it, there are a few of those in the world. This lady very interesting, came into nursing home from hospital because her husband was already in care with quite severe cardiac failure. He was cognitively good, but could barely move. He was so frail and fragile. This lady was very aggressive towards husband and staff, interestingly, usually female staff. And she wasn't welcome back at the nursing home because of this when she came into hospital for a short period of time. The family conference revealed, or the daughter let drop that her husband had had a number of affairs in his earlier life, and the wife was always suspicious even if he was late home. Now, Mr. and Mrs. White were in separate wings of the care facility, and the daughter was sure that her mother was convinced her father was having another affair. So with the negotiation, Mrs. White moved into the same room as her husband. It was difficult because it wasn't dementia specific where he was, but her behaviours improved, and she is supported occasionally by volunteers who get her out for short periods of time, but it's working. I suspect her husband won't see Christmas, so it'll be interesting to see what happens then. And finally, this lovely lady in residential care, she'd moved down from Orange to this particular facility because her family were nearby. She had quite severe dementia. She'd had a hip fracture with not good surgery, and she couldn't mobilise following fixation of the hip fracture. And she was constantly calling out for her son, but then when someone arrived, she didn't know what she wanted. And there was a lot of discussion about dogs, and because she'd had dogs all her life, having lived on a sheep property. So one of the staff members brought their Kelpie in to visit her, and this lady's eyes apparently just lit up and she smiled for the first time in weeks. So the staff member kept bringing the dog in every day, and he would spend several days in her room, and her calling out reduced hugely. And what was amazing was she died one day and the dog howled and howled, and that's actually how they knew that Mrs. Jones had died. But I think we could say she died happy, and it was lovely that the facility allowed, you know, that to happen. So that's the end of non-pharmacological. Just to have a look at pharmacological, and I won't spend nearly as much time on that because really I think we shouldn't be spending a lot of time on that, because hopefully we can deal with most things without using medication. And there's some rules. You only use medication after a reasonable trial of non-pharmacological measures, and you have to use judiciously. And goodness knows there are so many regulations around use of antipsychotics these days, or any of the psychotropic medication. And what we have to remember is that the efficacy of lots of these drugs are pretty modest. You know, they're not wonder drugs, but the side effects, excuse me, can be serious. So, I'm talking too much. You can tell I don't like talking about pharmacological management. So, you need to decide which symptoms are you targeting and measure what you're doing. So are you addressing the hallucinations, the agitation, the resistiveness in care? You've got to think about what you're treating and look at any underlying causes. So I've said it again, and I'll say it again and again. Check for delirium. Treat the underlying cause. Think about analgesics for pain. There was a wonderful study published in the British Medical Journal about 10 years ago that looked at using analgesics to treat agitation, not pain, agitation, and it was very successful. Sometimes it's just paracetamol, sometimes you need something stronger. And certainly look for constipation and think about laxatives and lots of fluids, because older people don't drink nearly enough fluids. And always involve the carer and other family members and staff when you're talking about this. Family members in particular, because they've got to consent to a lot of what you're going to use. So for agitation and anxiety, we know that the SSRIs, so antidepressants, are as effective as antipsychotics for agitation, not depression, agitation. And citalopram has the most evidence for it, and that's all there in those clinical practice guidelines I mentioned. We know that analgesics, as I've mentioned, reduce agitation. Antipsychotics may be effective, and risperidone is the only drug listed. But olanzapine can be effective, but you're using it off-label. And benzos may be effective, so use the short-term ones. Lorazepam is probably the one I would recommend most. Do not use Valium, diazepam. It is way too long-acting. For depression, the SSRIs, certainly I mentioned citalopram. If someone's quite severely depressed, go for one of the dual-acting ones, the selective noradrenergic reuptake inhibitors such as venlafaxine. It's interesting because in dementia there is no evidence for the use of sertraline or mirtazapine as antidepressants. That was quite a paper published in the Lancet a while back. So you do need to be careful about what you use, and why people use Zoloft for older people, I do not know. We have perfectly good antidepressants with citalopram, and mirtazapine, you know, it just helps sleeping. For aggression, again, risperidone is the only one. And this is one where, you know, I will use it if I have to. I really will. And olanzapine you can use because you can use it IMI. For psychotic symptoms, hallucinations and delusions, this is the easiest one. You treat if there's distress to the patient or to others. And I always use antipsychotics, risperidone, even for people with dementia with Lewy bodies. All antipsychotics will cause dopamine blocking. So use the one you're familiar with. It's the one that's listed, and that's risperidone. Very, very low dose if you really think you need it, and use it as a trial and see what happens. For sleep-wake cycle reversal, always think about melatonin because that's a really good way to induce sleep. It's not sedating, it simply induces sleep. For apathy, we know the cholinesterase inhibitors can really be very useful if someone's not on them already, and I think that's important to look at. And also antidepressants if the apathy is part of depression. There are some symptoms which you can treat with everything you like in terms of medication, and it doesn't work. That's the inappropriate vocalizations, so the calling out or the shouting out. Restlessness and wandering, and sexually inappropriate behaviours, which I'll give you an example of in a little while, which can be really difficult to manage. It's also important to remember about obtaining consent for treatment. In New South Wales, psychotropic medications, so antidepressants, antipsychotics, sedative hypnotics, are all major medical treatment, and they require written consent from the person responsible or the guardian if there's a guardian with a function of medical consent, and the person themselves can't consent. So it's really important to remember that we do need to get consent for these drugs. However, if something is urgent, urgent medical treatment is treatment necessary to prevent serious damage to health, and it does not need consent. You just get on and do it. So in an emergency, you could use psychotropic medication, and we might use it in hospital if someone is really very, very, very agitated and aggressive. You can do it without consent because that's urgent medical treatment, but then the next doses will require consent. And you should get on to the person responsible, that is the person who can give consent, within about 24 hours. So some examples. 68-year-old lady, 2-year history of Alzheimer's disease. She was on dementia. She was convinced her husband was having an affair. We're hearing a bit of this. She was convinced that he was going to leave her, and she followed him around. She got angry when he went out to golf. She stood at the door and physically wouldn't let him out. We commenced her on risperidone on the basis that she was experiencing delusions, and after 2 weeks, her husband reported to the GP, "I have got my wife back." He was very reluctant to consider reducing the dose of what he called the chill pill, and we all call the chill pill now, after 3 months, because he just did not want to go back to the screaming wife that he had. But we did reduce it after about 6 months to morning only, and it was stopped after a year, which is about 6 or 8 months ago. But her husband has a box in the cupboard at all times, he says, just in case. This lady who had mixed dementia moved into residential care after the death of her husband, who was her carer. And she became incredibly anxious and agitated about where her husband was. She was constantly asking staff and residents. And then when someone said, "Oh no, dear, you know, your husband's passed away, he's dead," she became incredibly distressed and said, "Well, why didn't anyone tell me?" And it was really, really difficult. And all attempts at distraction, exercise, music therapy, all those attempts failed. We started her on citalopram because of her agitation and possible underlying depression, but it was particularly her agitation, and went from 10 to 20 milligrams over a few weeks. The staff noticed reduction in questions because they had a behaviour chart after she got to the full dose. And she's been on citalopram pretty consistently, and probably will be for quite a while, because when staff tried to halve it and withdraw it, she started, you know, asking where her husband was again. And while she did occasionally ask about her husband, she didn't get nearly as distressed when told he wasn't there. This man, this is one of the difficult ones, lived in dementia-specific unit. His wife also has dementia. She is quite significantly impaired. He's only really got mild dementia. He started becoming much more attentive to female residents, and this sort of went from just walking with them, touching their arms, and then touching their breasts. And, you know, the staff tried, they distracted him, they monitored, they kept him out of one of the lounges. He was only allowed in one of the 2 lounges in the facility. They kept him active in the garden. We tried him with risperidone, no effect. We tried him with valproate, which is a mood stabilizer, so an anticonvulsant, Epilum, and a mood stabilizer. It made him drowsy, but he sort of kept going with the behaviour. And as the female residents were starting to report the touching and sexual assault, this required reporting to the Aged Care Quality and Safety Commission, and New South Wales Police were called. They actually were quite good. They spoke very firmly to Mr. James. They came at least twice. And after 3 months, he hadn't repeated the touching. Unfortunately, I have to report that he has started doing that again, and the facility will be looking at moving him because of the effect on other residents. But, you know, we used what we call police therapy, and it was effective for probably close to 6 months, but not permanently, unfortunately. This lady, this was a very sad, but in a way we were able to fix it. This lady, 77-year-old lady, lived in her own home. I'd been looking after her with her Alzheimer's disease for quite a few years. And during the 2019 bushfires, and this is down the south coast where I work, she was convinced she was the cause of the fires and that they'd been sent to punish her. And nothing we could say would disabuse her of that fact. She became incredibly distressed and she tried to stab herself with scissors. She was commenced on both risperidone and venlafaxine because the old age psychiatrist felt that, you know, she had both delusions and depression, and certainly I'd started the risperidone, but she did need the venlafaxine as well. She needed to come into hospital. We looked after her in hospital for 3 weeks, but she was markedly improved after 6 weeks, and we were able to stop the risperidone. It must have been early this year, no, late last year, and she remains on the venlafaxine now. So they're just some examples. My final slide is around call for help if you need it. DBMAS. The numbers here, 1800 699 799. The referral takes a little while, but it's worth it. And they will come out to private homes or residential care facilities. If it's really urgent, we have the Severe Behavioural Response Team, SBRT, which is part of DBMAS, but is only for residential care. And I want to mention the Specialist Dementia Care Program. They're units of about 10 beds that are going into residential care facilities with extra funding to look after those really, really difficult people who can't be managed in a normal aged care psychiatry unit or in a residential care facility or in other hospital facilities. And there is to be 1 per primary health network area, so 31 across the country. And I think that's really important in terms of having some help. And with that, I will stop. I'm not sure if you want to have a little bit of time, just if there's any comments, but I think we should stop there. So thank you very much, and the presentation will be available.
Thanks for that, Sue. My name's Ellen Minell. I'm from the Primary Healthcare Network. There are a couple of questions for you. Steph Anderson asks, hi Sue, are the sleep-wake disturbances you see in Korsakoff's similar to those seen in other forms of dementia? And could you outline the best approach for managing this?
That's really interesting. Thanks for the question. I haven't seen a lot of Korsakoff's psychosis lately, but I'm assuming it's the same issue where in dementia you lose cells, neurons in what they call the suprachiasmatic nucleus, which is our body clock. So our body clock is basically destroyed. So it's trying to work out how do you get someone knowing that when it's dark, it's time to go to sleep. And that's where melatonin comes in really, really handy. You can get it as Circadin. You can buy it online. It's much, much cheaper as long as you've got a good supplier. And what we suggest is during the day, you keep that person as active as possible and don't let them nap because they will try to. And then give them the Circadin or the melatonin in the mid-evening after hopefully some exercise and a reasonable meal. Observe the sleep hygiene and then cross your fingers, basically. Sometimes you can use temazepam as well as the melatonin, remembering that all melatonin does is tell your brain that it's dark and it's time to go to sleep. It doesn't actually sedate, but it does allow someone to drop off to sleep. It's keeping them asleep after that that's important. That's why you need to keep them awake all day. That's what we use. It's not easy, and often we have to make sure that we recruit all the family members to help with that. And if you really need to, then, you know, use of something like temazepam for a short period of time, remembering that it stops being effective after, you know, if you take it for more than about 10 days in a row. It works best intermittently.
Thank you. Next question is from Yasmin. Is it detrimental for the person with dementia to follow their hallucinations? E.g., if the lady with the imaginary kids approaches me asking if I know who owns the kids and I say they are mine, or, oh, we were babysitting them, that is why they are, will they impact negatively in the future?
I think that's a wonderful way to deal with it. I think we really need to, you cannot argue with them. They will not do that. And so I think that's a lovely way to say they're mine, you know, or I've been babysitting them. Someone else says, oh, thank you so much. I was late picking them up from school. And often that works. We see it, for instance, the classic for me was someone who had a crocodile under their bed in hospital. And he described it beautifully. He had dementia with Lewy bodies, we knew that, but this crocodile was there and it was worrying him a bit. So I was able to recruit 2 PSAs, 2 wardsmen, and they couldn't believe they were doing this, but they went in with ropes and they pretended to wrap up this crocodile and take him out the door, and they did. And that man was happy. Now, don't ask me, you know, whether that was the right thing or the wrong thing, but I can tell you it worked and everybody was happy. And the PSAs who did it still talk about it quite a few years on. So it's going with it. You know, it's sometimes they will know it's a hallucination. I have one man who, and it was wonderful, we had medical students and I knew he was hallucinating. We talked about his hallucinations and I said, how do you know whether they're hallucinations or they're real? And he said, he just looked at me and reached out and touched me and said, I feel them. And if I can feel them, I know they're real. As another man who says he walks his walking frame through the carpenter who comes into his room each night. Why it's a carpenter, I don't know, but he describes him right down to the carpenter's belt and the hammer you know, that he's got on. But if he walks his walking frame through him, he disappears. Another lady I've got down the coast has little people who come into her room, into the lounge room, and she shouts at them and they don't go. But her husband shouts at them and then takes her out of the room. And when she comes back, they've gone. And this was as recently as 3 weeks ago. She was telling me this when I was down there. So the husband has worked out how to deal with it. but he has to get his wife out of the room. She sort of knows that they are hallucinations, but at the same time, they're still very real to her, and she'll describe them. She described the one with plaits and, you know, what they're wearing, and they're wearing school uniforms. So, but she calls them her little people. But they don't worry her as such, except she thinks she has to give them afternoon tea, which is a bit of a problem because she then eats it. But yeah, it's very interesting. But my feeling is you do what is best for the person. And if you have to tell fibs, let me give you an example with my dad, who's been dead 5.5 years, and Mum until recently used to ask, you know, where he was, and we arranged that the staff at the facility would say, oh, you know, he's always at meetings, because they had tried he's probably at the hardware store, and Mum looked at them and said, rubbish, Stan has never been to a hardware store in his life. And he hadn't. So it was really appropriate, but he was at meetings as a headmaster. He was at meetings all the time. And she accepted that. The fact that he's, you know, in an urn on our piano, I would never say that to her. And even to this day, I'm not sure she's totally aware that, you know, that he's actually died. But you do what's best for the person. And if you have to tell a little white lie, so be it.
Sandra asks, how do the DBMAS work in rural areas right now, especially during COVID? Is it mostly phone advice?
It is mostly phone advice, but we actually jumped up and down and got someone to come out and see someone recently, one of our more difficult touches, as we call them in, and they came in person. So they will do it, and they certainly go rural. I've got colleagues who fly into Catherine to all, you know, pre-COVID lockdown. Yeah, but with the lockdown, particularly if you want an aged care psychiatrist, in New South Wales at the moment and Victoria, it's all phone. Fortunately, South Australia, WA and Queensland, you know, have their own so they can move around. But yeah, start by phone, but be persistent. If you're not happy with the advice, you know, say this isn't working, what else do you suggest? They will actually assist with staff at times as well. So, you know, they're a really good service, but, you know, they can be variable. And so make sure you, you know, you ask regularly. If you're not happy with what's happening. Certainly, I know they're in Tamworth. There are certainly colleagues working there.
Thank you. One from Claire Stevenson. Thanks for a great presentation, Sue. I just have a question about the case study about the lady whose husband had passed and how agitated she became when orientated to the fact that he was dead.
Really difficult situation. The family had photos of her at the funeral next to the coffin. We tried reality orientation, if you like, or the family did, and it just didn't work. It was really sad. Staff, you know, they tried to say, well, he's not here at the moment, maybe he'll come later. But even with that, she wouldn't settle down. She had that existential anxiety that is really hard. I was surprised it only took citalopram to settle her. I thought we might have needed something, you know, maybe a combination of a dual-acting antidepressant and antipsychotics. But, I mean, I think I've made the point I try and avoid medication when I can. And with risperidone, you're only allowed to prescribe it initially for 3 months anyway, and then you've got to ring them and answer a whole lot of questions to get the second script. So there is a very strong push not to do it. But GPs get around it all the time simply by writing private scripts. So it's not an authority script. You write a private script and it's about $60.
Yep. One more from Alina Roper. Thanks, Sue. Really interesting presentation. Can you use the dementia services described for queries and assistance with NDIS participants, those with early onset dementia or Down syndrome with dementia, or are they for aged care only?
No, the person just has to have dementia. And we have this, you know, a bit of a, I guess, an argument with them. But as long as the person has a dementia, that's fine. And younger onset, fine. They've looked after one of my 61-year-old lady that I had. They were fantastic. I'm not sure about payment because, of course, they're free. They're Commonwealth funded. So, but they've certainly helped at least one of my NDS clients with younger onset dementia very well.
Beautiful. Sophie Bailey has made the comment, DSA is operating as usual during COVID. I'm a DSA consultant in Tamworth, and we're working across the country and providing the care provider is happy to have us there. We'd love to hear from you.
Yeah, thanks, Sophie. I didn't want to drop you in it because I wasn't sure where you're at with your little one, but thank you for saying that. Yeah, absolutely, DSA or DB Mass, DSA is the sort of parent, are definitely there. Thanks, Sophie. Yeah.
There's one, this is a silly question, but we are having trouble accessing iPods for our residents now. Can you advise where we can purchase these with headphones?
Look, agree, because of the issues with chips and not being able to get them. JB Hi-Fi had them recently because we had this problem about 6 weeks ago, just after the lockdown started, and they were able to get some from JB Hi-Fi. The alternative is look on eBay, because there may be people, the problem is you don't want to get a dud, but yeah, the iPods are good. If all else fails, you just put Andre Rieu on, you know, on the player for everyone to listen to. But I think if I listened to Andre Rieu again, I'd probably be sick. But it works wonders with older people. So, you know, there is something in his music. The Sound of Music is the other one that we often use, and Hymns of Praise, I think it is. We've taped a few that work quite well. Sound of Music is lovely. I had everybody singing the Do Re Mi song the other day, Where Mum Is, because I was singing it with her, and then 2 other men joined in, and it was quite amazing. And of course my grandchildren can sing it too, so you know, it's across the generations. That's probably the main one that's across, and My Fair Lady would be the other one.
There's lots of comments coming in, Sue. Thank you so much, especially for all the case examples. It really helps us understand symptoms and manage better. So thank you. I'll hand over to Jenny, and we'll go from there. Thank you.
Thanks, everyone.
Thank you very much, Sue. They're very informative and many, many positive comments coming through. We've gone a little bit over time, but definitely the level of engagement and people very, very interested. I know it's hard when you're on remote presenting and you don't get an applause at the end of the presentation to get some validation. I think I've sorted that out for you though, Sue.
Not more Muppets.
No more Muppets, just a nice virtual applause. So look, thank you again for that very informative presentation.
It's a pleasure, and as I said, I think it's going to be available. Jenny was going to take a copy of it later on. Okay, I hope the rest of the day goes really well.
Thanks very much, Sue.
Thanks. Bye.
Now, we are going to pause. It is the lunch break. We've got 3 presentations for the afternoon session. We are going to reconvene at about 1:45 this afternoon. Now, during the lunch break, there will be a number of informative videos playing during the break if you'd prefer to watch, look, particularly if you've got school-age children at home and there is a risk or you may be bombarded with schoolwork questions. We're giving you a little bit of an out. You can go back to the computer and watch some videos and just say that you're in the middle of work. So look, thank you again for your attention. All your questions, we'll take a pause for lunch and we'll meet you back here at 1:45.
Dudes and they were out on the street. They were clearing out the empty lot and making it neat. I said, man, is this cool? What you trying to do? They said, making a garden for me and for you. They said, hey man, join us, come on, let's go. Together we can make a pretty garden grow.
I'll dig a
what you trying to do? I said, make a street garden for me and for you. I said, hey cats, join us, come on, let's go. We'll all cooperate and make a garden grow. You dig a hole and I'll plant a seed, and we will add the water that all growing things need. Cooperation makes it happen. Cooperation, working together, dig it. Cooperation makes it happen. Cooperation, working together. Now we watch our garden grow and we come back every day, and the people in our neighborhood come round and say,
Hey man, this is cool. Tell us what we can do to keep this pretty garden here for me and for you. We all say, hey, join us, come on, dig the seed. We'll all cooperate and keep our garden green.
You trim the leaves,
And you pull the weeds.
and I will add the water that all growing things need.
Cooperation makes it happen. Cooperation, working together, dig it. Cooperation makes it happen. Cooperation, working together, dig it. Cooperation makes it happen. Cooperation, working together, dig it. Cooperation makes it happen. Cooperation, working together.
So, without further ado, I'm now going to introduce our next presenter, Patrick Cashman, who is the Immunisation Coordinator for Hunter New England Local Health District and resident friend, because he has done a lot of these for us, and a lot of you will know Patrick he's been in the space for a long time and has an incredibly large amount of information and knowledge related to all things vaccine and vaccine safety. Patrick initiated and also does manage the Vax Tracker active surveillance system for adverse events following immunisation, and is part of the AusVax Safety Consortium. So I'm going to hand over to Patrick now, and I'll be back at the end to talk about question time.
Thanks, Kimberly. That's great. Can you see my slides?
I can.
Great. Fantastic. So I'll talk about vaccine hesitancy. Thank you very much to Hayley for presentation. That was really good. There's lots of different ways to encourage people to get a vaccine, any vaccine. And the most important is the top there, access. Now, as all of you've worked in residential aged care, you've had teams come around and immunise the residents there. We've missed the boat in terms of not immunising staff. I think that would have been lovely for the government to show care for the staff and immunise them at the same time. But that ship has sailed. But now we're asking you guys to step up and to make sure that you don't make the same mistake as the government and forget to vaccinate yourselves. So really, really important. Now, a lot of people in the community aren't able to get the vaccine yet because they're not in a priority group, but you guys are all in a priority group. So you've got access to the vaccine, but you've got to do it yourself in your own time. It is free, but it's not just going to turn up at your doorstep. And some of these other things we'll address and Hayley's already addressed. So how do vaccines work in general? Well, in general, the bacteria or the virus on the left, we get a little bit of it and introduce that to the immune system, and then the antibodies recognize that, and it's a sort of a lock and key mechanism, so that the lock is the antibody and the key is the antigen from the bacteria or the virus, and then you can remember that. And when you meet that again in the next time, you only need to cut the key once, and then you can open that door every time, and that's what the antibody does. Now, this is the coronavirus and the famous spike proteins on the outside, and it's called corona because it's like a crown, and the spike proteins under the microscope give it a crown appearance. So with the AstraZeneca vaccine, there's a little bit of the DNA that's taken from the coronavirus, and then that's put inside an adenovirus. So this thing up here is an adenovirus, and an adenovirus is a common cold virus. And there were some questions about why the adenovirus for the AstraZeneca vaccine is a chimpanzee adenovirus. And the reason is because if it was a human adenovirus, or an adenovirus that affects humans regularly, your immune system would already be immune to it. So it wouldn't let that adenovirus carry that bit of DNA into your body. So the adenovirus, what it does is it protects the DNA. You can see the squirrely bit of red DNA on the inside of the virus there, protects that so then it can get inside your cell, and this blue one here, and then it pushes the DNA into the nucleus and it makes messenger RNA. Then on the right-hand side, the messenger RNA is like a story, and it tells the cell then to make the spike proteins that then display on the outside and stimulate those antibodies. Now, the mRNA vaccines, the Pfizer vaccines, don't have that adenovirus to protect them. So and it's an RNA vaccine, it's not a DNA vaccine. So the little bit of RNA floats around freely, and it's in a little fatty capsule there, and then that gets into your cell and it tells the story. So it's not like the first one I showed with the lock and key. It's not like the key, which is how most vaccines work. You put the key in and then it makes lots and lots of keys so you can keep opening that lock all the time. It's actually telling the cell how to make it. So it's like having the locksmith in your cell. It's telling how to make those keys. And then this funny shaped thing over here is your immune cell, the dendrite cell, and that makes the antibodies when it's challenged. And that's the Pfizer vaccine and the Moderna vaccine. That's the vaccine we're using for people under 60 in Australia. So this is a different graphic of that same vaccine. And I just draw your attention to this middle one here, the pink one, because the messenger RNA, the little story about the RNA, is contained in a little fatty globule there that contains the little messenger RNA. So then when we look at the ingredients, so people have asked for this webinar, what are the ingredients in the vaccine? On the left-hand side is a list of everything that's in the Pfizer vaccine. If we have a look at it, the top dot there is the active ingredient. That's the messenger RNA. That's the little squiggly bit we saw on the diagram. And then the next four are lipids. Lipids are fat, so lipid, 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 lipid. And they're the casing around the messenger RNA to protect it. But it's still very, very fragile. We know those vaccines have got to be deep frozen at -70, then they can be kept in a fridge unopened for a month. And then when you're mixing it up, you can't shake it vigorously because that will destroy it. So the lipid casing's very fragile, but it protects it enough so we can transport it. And then you've got some salts and some sugar. So there's really nothing in that vaccine that's going to cause you any problem. It's a lot of these things you'll find. So potassium chloride, cholesterol, you know what cholesterol is, it's in your own body anyway. Sodium chloride's common table salt, sucrose is sugar. So these are things you have in your kitchen anyway. So these are nothing to be afraid of. And on the right-hand side, the AstraZeneca, a very, very similar story. Polysorbate 80 is a surfactant, so that stops the vaccine being absorbed into the glass of the vial. And polysorbate 80, it's contained in lots of things, cosmetics, and it's contained in lots and lots of foods, including soft ice cream. So you might not want to have soft ice cream every day. That might not be healthy for you, but in this sort of quantity, it's not a problem. So there's nothing nasty in these vaccines that's going to worry you. Now, vaccine safety is really, really important. So for the vaccines, have got to pass some trials, phase 1, phase 2, phase 3, phase 4. Then we do this phase 3, and then phase 4 is what happens out in the community. We've got to keep an eye on the vaccines to see what's happening, and that's the Vax Tracker system that I made. We've got over 1 million people in it now. We do these phase 4 studies where we're looking to see what's happened, because the phase 3 studies the company does may have some tens of thousands of people in it, but now we've got millions of people and we can find out new information. And vaccine safety is a little bit like being a lifesaver. So people say, well, why are the rules changing all the time? And it's a bit like on the beach. It's a dynamic situation. So if we set up the flags and we know people can swim there, people know, they come and see the flags, they go, oh, it's safe to swim here. That's fantastic. I've got my lifesaver hat for a prop. and people say, oh, you can swim here. That we know it's safe. But then if a rip opens up between the flags, the lifesavers are looking at the conditions and then they make changes. They're going to move the flags up the beach where there's no rip. And it's exactly the same with vaccine safety. So ATAGI are like the lifesavers. They're keeping an eye on all the data. And if they notice a problem, then they changed the rules. So AstraZeneca was able to be given to anyone, and then we noticed the problem with the blood clots, and ATAGI said, well, let's not give that vaccine to anyone under 50. And then they noticed more problem with blood clots, and they said, let's not give it to anyone under 60. So that's why the rules change. And the rules changing is a good thing, because it means we're watching, we're keeping an eye, and keeping good surveillance and making things as safe as possible. So this is some of the data from OzVac Safety. We've given over a million surveys to find out what's happening. And these are common side effects. So a lot of people report common side effects. So nearly half the people. So if you do get the vaccine, it's going to knock you around a bit, but it's going to protect you, like Haley nicely pointed out. So this is a really nice graphic from ATAGI about on the left-hand side is the different age groups in the orange column, and it's the risk of the blood clots with the AstraZeneca vaccine for every 100,000 people. And this is in a situation, like a medium situation, which is like the outbreak in Victoria not long ago. So you can see here for young people, there's a risk of blood clots. But then as we get older, the risk of blood clots falls away. So people over 60, the people between 50 and 59, the risk of blood clots is 2.7 per 100,000 people. But for 60, it falls away to under 1.5. Whereas if we look at the blue side's the risk of disease. What happens if I get COVID disease? Now, the little dot at the top are deaths, and the bright ones underneath are ICU admissions, and the dull ones underneath are illness. Now, you can see here that as we get older, the illness gets bigger. And on the left-hand side, as we get older, the risk of blood clots gets smaller. And then ATAGI has decided, by looking at this sort of data, saying, well, if you're over 60, getting the AstraZeneca is the best thing to do. Whereas if you're under 60, the risk of the blood clot is probably too high for the risk of the disease. So if you're over 60, having that AstraZeneca is really, really important. If you've had the first dose of AstraZeneca, really important you go back and get the second dose, because the risk of blood clots with the second dose is greatly, greatly diminished. It's really a first dose problem. If you've had one dose of AstraZeneca and you haven't got a blood clot, you're going to be fine with the second dose. The risk is really small, not zero, but nearly. So the thing with the TGA is they collect all the data that we do a lot of investigating of anyone who's been to hospital or anyone who's had a bad outcome after the vaccine. Now, this is the blood clot data. This is publicly available on the TGA site. See, this is from last week, and you can see here on the bottom, 76 people, 36 men and 40 women in Australia have had the blood clot problem. So lots of people have had the vaccine, but only 76 have had the blood clot problem. Now, that's really decreasing now because we're not giving that vaccine to anyone under 60, mostly, unless they really want it. Again, this is from the TGA. You can see here that the blood clot, 22 people have been treated in ICU for the blood clot, 6 previously, and 2 people have had a fatal outcome from the blood clot. Now, if you've had a history of blood clots in the past, you've had a DVT or you've had a pulmonary embolus, anything like that, or you've got a history of blood clots, or you're on any anticoagulants, you don't have to worry, because the issue with the blood clot is really a problem caused by the immune reaction to the vaccine, whereas normal blood clots are not immune mediated. So if you've had a DVT before and you're over 60, you can safely have the AstraZeneca vaccine. The risk of blood clots for you is no higher than for the next person. So having a history of blood clots, or a family history of blood clots, or a history of ischemic heart disease or strokes is not a contraindication to getting the AstraZeneca vaccine. So if you're over 60, you've got a history of clots, still talk to your GP, get personal advice, but it's not a contraindication. Now, in terms of understanding vaccine hesitancy, there's lots of ways we think about risk. I'll take my hat off now. Lots of ways we think about risks. And it's the way our mind works. And this is what the psychologists called heuristics. And so it's a mental shortcut, how you balance up risks. Now, you may have heard something hearsay, people may have spoken to you, and then you process that and you say, oh no, there's a risk of blood clots with the vaccine, or I'm worried about this with the vaccine, or my pastor said that about the vaccine. But really you need to understand how we make these decisions. So some people anticipate the negative emotions of a decision and avoid taking the course. You think, I don't want to deal with a vaccine, I'm going to put it in the future, I don't want to deal with that now. Some people say, well, if I don't do anything and something happens, that's better than me doing something and then something going wrong. So I'm not going to go and have that vaccine. So that's what we call an omission bias. And then if we avoid taking risks when the outcome's uncertain, if we think taking the vaccine's uncertain, and then we avoid having the vaccine. So this is the way our mind works. So when we're looking at having the vaccine, we've got to understand how we make decisions. Now, you don't need to know all the information, but Hayley's given you some really good background. Vaccines are incredibly safe. Nearly everyone on the planet gets offered a vaccine. We're trying to reach even the poorest people in third world countries with a vaccine to protect them so they can grow up strong. So these are really tested products. We know there's been hundreds of millions of vaccines given in the United States, in the United Kingdom, all over Europe, and we're trying to get them out to other countries in the world. These are not untested products, and everything is open. Everything's on the TGA website. There's nothing hidden. So you don't have to worry if you've heard some bad stuff about vaccines. You can put that to one side and make a decision that, no, I can see vaccines are the right thing to do. But there is a lot of misinformation. So this on the left is a terrible letter drop that come from Clive Palmer's group where he's trying to scare people. On the right-hand side is the real data from the TGA. So if you look at that middle box on the right-hand side, you can see there that 36,000 reports of an adverse event have come into the TGA, but that's a good thing because we want to know what's going on. Now, most of those are just a sore arm, or people have had a headache, or people have had a day off work and they report to the TGA they've had a problem after the vaccine, but they're mainly minor. Yep. Now, if they're serious, like the blood clotting problem, then we find those issues and then we can change the rules. Oh, let's not give this vaccine to anyone under 60 because we're worried about the blood clots. So out of 8 million doses given in Australia, 36,000 reports, and most of those are trivial. So what the Clive Palmer group's done is they've looked at this data and then made a big fuss about it and taken the numbers and tried to misrepresent them. So it is good news because everything's open. Now, you may be, maybe you're not born in Australia, or maybe you come from a country where the government hide information and you're worried about how honest the government is. Well, in Australia, the TGA is the government's representative in terms of making sure all medicines are safe. When you go to the pharmacy, all those medicines on the shelf are approved by the TGA, and the TGA can do that because they're open and transparent. So the government in Australia is not trying to hide anything. There's no hidden things here. This is just on a public website. You can go and have a look at it. You can talk to your doctor or your family about it. There's nothing hidden. So when you see these things that are misrepresenting the information, or you hear some bad stuff about vaccines, don't let that sink in and then you make a decision about not having the vaccine. If you're thinking about not having the vaccine, really try to explore it with someone. Now, if you're talking to people who are worried about having the vaccine, then don't judge them. So this is a wonderful graphic from Julie Lee's group. It's available on the net. So it's really important that you listen and be curious and try to find out why someone's making that decision, because you're not going to badger them in to having the vaccine. And then you may be able to find ways you can talk to people about having the vaccine. You can say, well, you're obviously concerned about your health. What are your worries about having the vaccine? So here's a good example. This lady on the top says, oh, the vaccines have arrived so fast. How do I know they're safe? And this guy's saying, well, COVID vaccines went through the same safety checks as any other vaccine, any other medicine, but rather than the science being sped up, it was the administrative side and the funding side that was sped up. For example, if you're a big company and you're making a vaccine, you've got to go through all those stages, stage 1, stage 2, stage 3. So you're not going to build a big factory to build vaccines and make vaccines if the trials are still going, because you want to make sure that product's been approved before you start to build the factory. But with COVID vaccines, everything was happening at the same time. Everything was happening in parallel. So before the vaccines got approved, the factories to make the vaccines were already being built. So things were happening in parallel rather than one after the other. So the reason the vaccines are on the market quickly is because of the need, because we need to get the world back to normal, and because things were done at the same time rather than waiting. So it was the administrative side that was sped up, not the science. All the safety steps were done absolutely judiciously. Now, people are asking, well, if I get the vaccine, can I still pass on the virus to someone else? And this is two recent studies that are saying that the vaccine does a lot in terms of stopping you transmitting the virus. The left-hand one is a study from England involving 365,000 households, where they looked at, well, if someone's got the vaccine and then they get the virus infection, are they passing it on to their household members? And they found that over 50%, so it stops half the transmission if you're vaccinated, and that's household members. That's people you're living really, really closely. So for casual contacts, it's going to do even better. So that's a huge result. The one on the right is an article from Nature Medicine from an Israeli study where they people who were vaccinated, and then they did swabs of the nose, and they found that the amount of virus up the nose of a vaccinated person was greatly decreased compared to an unvaccinated person. So vaccines are really good at protecting you, over 90% chance of keeping you out of hospital, and they're good at protecting the people around you. So if you think of the nursing home outbreaks that we saw last year in Australia, in Sydney and Ryde, and there were dozens of residents who got sick with COVID, who went to hospital, and you compare that to the 2 weeks ago, there was an outbreak at a Balkan Hills nursing home. Only 5 residents went to hospital, and they were all right. So nearly all the residents were vaccinated, and only 5 had to go to hospital, and they're all okay. No one died because the residents were vaccinated. Now, only 1/3 of the staff had been vaccinated, which means 2/3 of the staff had to be excluded from work for 2 weeks because of they weren't vaccinated, and they needed to protect the residents somehow, so they had to pull those staff out. So if you're a staff member in an aged care facility, your ability to protect the residents and to protect yourself and to protect your colleagues is really high if you go get that vaccine. Now, it's a hassle to go get that vaccine. Liz, at the beginning of this meeting, made it clear that they really want aged care workers to get it. So the Belmont facilities there's the hubs in Tamworth, Taree, Armidale. So there's places where you can go get it, or you can get it from your GP. If you're over 60, the AstraZeneca vaccine. If you're under 60, the Pfizer vaccine. So you really need to look at the science, look at how important your role is, and see the difference between what happened in nursing homes last year compared to this year. It's chalk and cheese. So you don't want to be the person who's unvaccinated bringing that virus into that nursing home. So you imagine the poor limo driver in the eastern suburbs a month or so ago, and he wasn't vaccinated, and he picked up some airport staff, some airline staff, and then he got infected, and now we've got this huge lockdown in Sydney. Now, you don't want to be that person. You want to be protected. You want to make sure that you're protected yourself, and you're not going to get sick. You're not going to end up in ICU. You're protecting your family. So when you go to work, you're not going to bring any COVID home to your family, and you're going to protect the residents and your colleagues. You've got a huge role. It's really, really important that you take the trouble to go and find that vaccine and go get it. At the beginning of this Sydney outbreak, after the problems in Bondi and Bondi Junction Shopping Centre, there was a party in Western Sydney in Hoxton Park, and there were about 40 people at the party. 34 were unvaccinated. They all got COVID. There were 6 who were vaccinated because they were healthcare workers. They were at the front of the queue, and all of them are all right. So these vaccines work really, really well. You can protect yourself, protect your family. If you've got worries or concerns about having the vaccine, talk to your manager, talk to your colleagues, talk to your GP. Don't let little things sitting in your head here worry you, and you make bad decisions. So if you've got to look at the evidence is that nearly everyone in the world gets vaccines. They're the most tested product. Hundreds of millions of people have had these vaccines that is on offer for you now. There's nothing hidden in them. There's no hidden agenda. Everything's up front. The safety data's up front. You can look at it on the internet. I've showed you here today. Hayley's given you a really lovely background. These things are much, much safer than getting the disease. So take the trouble and go get yourself vaccinated. If you've got worries, talk to someone and really test those worries, and don't let them make you have a bad decision. The government's already made one bad decision in not vaccinating you when they vaccinated the residents. Don't you add to that dilemma. Take the trouble and go get vaccinated. Thanks.
person living with dementia may not remember the day, but they can enjoy the moment. It's very important that carers, family and care workers introduce themselves to the person living with dementia. For example, "Hey Mum, it's Sal here, your youngest daughter." This can help orientate them to the context of who you are.
Carers do an amazing job in looking after the person for whom they are caring. They need patience, tolerance, kindness, compassion, and great understanding and acceptance. You're also human, so you're going to at times feel frustration and even anger. The important thing is to learn as much as you can about dementia and what this can mean for you and the person for whom you are caring. These videos for carers can't cover all the topics and we don't have all the answers. So we're just giving you a snapshot of some of the information available.
It's important to remember, if you as a carer have had to take over the cooking and the meal preparation, etc., to try not to take over completely. Why not ask the person into the kitchen? They might be able to scrub the potatoes or peel the potatoes, might still be able to chop some things, they just need that direction. And sometimes the companionship of doing it together doesn't matter if nothing's perfect. Sometimes people living with dementia like to walk a lot and they don't like to sit to have a meal. So consider having little snacks of finger foods around the house. The music can be very calming in the background and the lovely scenery in it can make a difference. It's important that you don't feel guilty about taking a break. You need those little breaks. Don't ever feel guilty about it. When a person receives a diagnosis of dementia, depending on which state or territory you might live in, you may have to notify the Roads and Maritime Services of your diagnosis. This doesn't mean you'll automatically lose your license. Sometimes people can be reluctant to have a shower or a bath, wash their hair, do their teeth. And there's a few things we can do with that.
I think it's really important to say that if exercise was a medication, if we could put it in a pill, it would be the most effective treatment ever marketed.
Please don't buy them mobility scooters when they lose their license. It's a recipe for disaster. Lower your voice. Talk calmly and softly. Sit with the person to help distract them and to take their attention off whatever's upsetting them, and try to center the focus back on themselves. Never underestimate the power of a cup of tea. Making trouble, they're not being difficult, it's actually just a disease process.
So if you're told, oh, it's cloudy 3 times today, you just acknowledge, yes, as if you've heard it for the first time.
You've got to learn to step into their world.
But on the whole, the majority of people like a hug. So from me to you, here's a hug.
Dudes and they were out on the street. They were clearing out the empty lot and making it neat. I said, man, is this cool? What you trying to do? They said, making a garden for me and for you. They said, hey man, join us, come on, let's go. Together we can make a pretty garden grow.
I'll dig a hole
and I'll plant a seed.
and for you. I said, hey cats, join us, come on, let's go. We'll all cooperate and make a garden grow. You dig a hole and I'll plant a seed, and we will add the water that all growing things need. Cooperation makes it happen. Cooperation, working together. Cooperation makes it happen. Cooperation, working together. Now we watch our garden grow and we come back every day, and the people in our neighborhood come round and say,
Hey man, this is cool. Tell us what we can do to keep this pretty garden new for me and for you. We all say, hey, join us, come on, dig the seed. We'll all cooperate and keep our garden green.
You trim the leaves,
And you pull the weeds.
and I will add the water that all growing things need.
cooperation makes it happen. Cooperation, working together. Dig it. Cooperation makes it happen. Cooperation, working together. Dig it. Cooperation makes it happen. Cooperation, working together. Dig it. Cooperation makes it happen. Cooperation, working together.
The person living with dementia may not remember the day, but they can enjoy the moment. It's very important that carers, family and care workers introduce themselves to the person living with dementia. For example, hey mum, it's Sal here, your youngest daughter. This can help orientate them to the context of who you are.
Carers do an amazing job in looking after the person for whom they are caring. They need patience, tolerance, kindness, compassion, and great understanding and acceptance. You're also human, so you're going to at times feel frustration and even anger. The important thing is to learn as much as you can about dementia and what this can mean for you and the person for whom you are caring. These videos for carers can't cover all the topics, and we don't have all the answers. So we're just giving you a snapshot of some of the information available.
It's important to remember, if you as a carer have had to take over the cooking and the meal preparation, etc., to try not to take over completely. Why not ask the person into the kitchen? They might be able to scrub the potatoes or peel the potatoes, might still be able to chop some things, they just need that direction. And sometimes the companionship of doing it together, doesn't matter if nothing's perfect. Sometimes people living with dementia like to walk a lot and they don't like to sit to have a meal. So consider having little snacks of finger foods around the house. The music can be very calming in the background, and the lovely scenery in it can make a difference. It's important that you don't feel guilty about taking a break. You need those little breaks. Don't ever feel guilty about it. When a person receives a diagnosis of dementia, depending on which state or territory you might live in, you may have to notify the Roads and Maritime Services of your diagnosis. This doesn't mean you'll automatically lose your license. Sometimes people can be reluctant to have a shower or a bath, wash their hair, do their teeth. And there's a few things we can do with that.
I think it's really important to say that if exercise was a medication, if we could put it in a pill, it would be the most effective treatment ever marketed.
Please don't buy them mobility scooters when they lose their license. It's a recipe for disaster. Lower your voice. Talk calmly and softly. Sit with the person to help distract them and to take their attention off whatever's upsetting them, and try to center the focus back on themselves. Never underestimate the power of a cup of tea. Making trouble, they're not being difficult, it's actually just a disease process.
So if you're told, oh, it's cloudy 3 times today, you just acknowledge, yes, as if you've heard it for the first time.
You've got to learn to step into their world.
But on the whole, the majority of people like a hug. So from me to you, here's a hug.
Welcome back, everybody. I trust you had a nice lunch break as we head into the next session of our New England Dementia Forum today. We're going to have 2 presentations before we take our next break, followed by a allied health bundle to end proceedings today. Again, you've definitely got the gist of it in terms of any questions of the presenters to put them into the question box, and Ellen will be able to see and facilitate. It's my pleasure to introduce our next presenter, currently the Acting Manager of Community Supports for the New South Wales Ageing and Disability Commission. Prior to this position, he's worked with the New South Wales Public Guardian, New South Wales Trustee and Guardian, and New South Wales Ombudsman. It's my pleasure to introduce Jonathan Harvison.
Hi Kevin, how are you?
Well, thank you, Jonathan. We can hear you loud and clear.
Can you see me as well?
Not yet. If you just click on your web, you did come on earlier, and you are here. We can see you.
Okay. All right. Thanks, Kevin, and hello everyone. I've got the afternoon slot, and I guess if we're meeting together, that would mean that everybody was trying to stop nodding off to sleep. But I guess that as everybody's working from home, you've probably all been catching up on the things that you would have been doing at work instead. So hopefully, sort of, everyone's not quite so sleepy. First of all, I'd like to acknowledge the traditional custodians of the land that I'm on. I'm in the inner west of Sydney, and the traditional owners are the Gadigal people of the Eora Nation. So I'd like to sort of pay my respects to previous, current and emerging elders. Thanks for the opportunity for talking to you today. You've had an impressive morning, I see, and hopefully we can follow on with some useful information for you. I'm from the New South Wales Ageing and Disability Commission, and I guess our prime focus is that we respond to reports about abuse, neglect and exploitation of older people and people with disabilities. this is difficult stuff for everybody, no matter how experienced you are working in the sector, no matter how long you've been around working with older people. When you come across this sort of thing, it's confronting stuff. And our agency has been established, I guess, to sort of as a resource to sort of help you and to help the community sort of respond, you know, in a better way to protecting people and sort of protecting their rights. So what I'll do is I will show you my screen and go through the presentation that I have. I'll do an initial part of the presentation which basically outlines the role of the Commission, and then we can stop there and maybe have some questions before moving into some case scenarios, which hopefully will illustrate sort of our work. So let me just see if I can share my screen. Kevin, you might just give me some guidance here.
Jonathan, it's Jenny. We
Jenny.
can see your screen. Have you
Yep.
got your slideshow up?
Yes, I have.
Okay, we can't see it.
Well, that's what I need to share. So what do I?
So do you have two screens?
Yes, I do.
So I'd say it's sharing the other screen.
Right. Not sure if I can see the other screen. I'm not sure if I can. Oh, you can see that now? Excellent.
Yes,
I'm not sure what I did there, so you mightn't see me again. Okay, so
we've just lost it again.
oh, have you? Can you see it again now?
No, sorry. I think, would you like me to share your slides?
Yes, that would be good then. Yeah, I think that would be good.
Oh. I've only got the PDF copy.
Right.
Sorry, just give us a few minutes, everybody. So I'm just going to take you off as the presenter and then resend it to you.
So do I click on the show my screen?
Yes, please.
Right, okay.
And maybe if you could drag your presentation across to the other screen that we're seeing.
Right. Okay.
Yes.
Okay, sorry everyone for that. Obviously, IT is my forte. Okay, so
that's beautiful now. Thank you.
right. Okay, good. No, sorry about that. Okay, so the Commission has been around for approximately 2 years and grew out of, I guess, a recognition that there was a gap in the response to abuse, neglect and exploitation sort of among vulnerable communities, in particular older people and people with disabilities. There was work that the Ombudsman's Office was doing. There was work that was being done by the Elder Abuse Helpline. And also there was some inquiries done by the New South Wales Law Reform Commission and also the National Law Reform Commission into elder abuse, which recognised that there was a gap in this area, particularly around sort of the ability to inquire into abuse and neglect. So the New South Wales State Government established the Commission. It was its first legislation that was passed in the new Parliament, creating the role of the Commissioner and his office. And you can see there's three basic sort of functions that the office was given, and really it can be categorised as one which is an active role in responding to abuse, neglect and exploitation, but also a broader role of protecting and promoting the rights of older people and people with disabilities. And these are the three sort of areas in which we do our work, and I'll move through each of those. So the first one is a role in advising government, both at sort of at a lower level, working with government agencies, either regionally, but also in advising directly government on sort of, I guess, what's happening in this space and what sort of need to be the policy and the service responses to abuse, neglect and exploitation. The Commissioner is independently appointed. He's answerable to Parliament, not to government, and he's required to report to Parliament yearly on the operation of his office, but also on various sort of recommendations that he might make. We've provided input into both Royal Commissions, into the Aged Care Royal Commission and the Disability Royal Commission, and we find that government generally is quite sort of keen to hear from the Commissioner on his views in relation to this area, and particularly at the moment as well, sort of how the impact of COVID is affecting people with disabilities and older people. The second area is community engagement. That's really sort of, this is part of what we're doing now. Is we've been given a mandate to go out and to educate the community about what abuse, neglect and exploitation is and what responses of the community should be. And really sort of the view of the Commissioner would be that commissions don't protect people, it's communities that do, and therefore what we need to do is to support the community to be able to identify and develop responses to supporting, you know, people who are vulnerable in the community to be safe. So we're more than keen to go out and speak to people, such as we are now. We're developing training resources, and at the end of the slideshow, you'll see our website. On our website, we have a couple of training modules which have been developed, and more are in train. One is a basic one about sort of recognising abuse, neglect and exploitation, and the second one, which has just gone online in the last week or so, is a module for managers, which is really about how they support their staff to identify but also respond to concerns that they are identifying, sort of if they're meeting with people. Another part of sort of our work in the community engagement space is very much about talking to people at a local level. So we, as a state-based organisation, our sort of we can do things at a certain level, but we also realise that sort of the core work that needs to be done in this space is by services on the ground. And so those services, the services that you're involved will, you know, are critical to supporting people, to helping them to keep safe, and also to providing them with options. One of the things that we also realise is, you know, that there are particular communities that we need to sort of reach out to, so Aboriginal communities, CALD communities, and we're very keen to sort of tailor our responses for those communities so that they're effective and that they feel that it meets their needs. And then the third area is managing inquiries and reports, and this is really the bulk of the work that we do. And I draw your attention sort of to the bottom paragraph of the slide there, which states that there's no mandatory reporting in this space, and I really want to stress that. unlike in child protection, where there's a range of us who have mandatory reporting responsibilities if we have concerns for the safety and welfare of children, there's no mandatory reporting when it comes to concerns about abuse, neglect and exploitation of older people and people with disabilities. All of you who work in clinical or in service provision settings will have policies and procedures which you are expected to follow. I know in New South Wales Health has policies around sort of responding to abuse and neglect for older people and people with disabilities. They're highly effective policies, and each local health district is required to tailor their response. That guidance is good guidance, and sort of and we encourage sort of people who work in health to go to that and be informed by that. And part of that process will be an expectation that sort of when you're seeing or when you're sort of suspecting abuse and neglect, that basically you report it elsewhere. And similarly for service providers in the field, approved aged care providers, there's expectations that they will have procedures in place to report concerns as well. So although it's not mandatory in terms of the law, there's clearly expectations, and we would encourage you to contact us if you have concerns around the safety and wellbeing of a person that you're working with. So let's look further at what that responding to reports looks like. Anybody can make a report to us. The legislation has been framed in such a way that it really wants to encourage people to make contact. And so if you're seeing something, that you say something. The Act provides important protections for people who report to the Commission. Basically, it's a crime under the Act if people are victimised in any way for reporting to us, but also that people can choose to remain anonymous or not to have their identity revealed. We are unable to reveal your identity if you make a report to us unless you provide your consent to do that. And I think that was a recognition that sort of, you know, people are often so sort of wary or reluctant to get involved around these concerns because, as we acknowledged before, this is deeply uncomfortable stuff. So really, the intent of the legislation was to try and provide as much encouragement as possible to get people to report concerns if they have any. And you'll note there's a couple of ways in which you can report to us. You can report by phone, by email, or by web form. Prefer if you didn't do the web form, really. Please get on the phone and give us a call. That's the best way to do it. And if you want to remain anonymous, although that's respected, we'd prefer that, you know, if you're willing to make a report, at least give us your name and contact details, because often when we're looking into a matter, we need to be able to go back to you to find out what's going on or to get further information. And obviously, you know, when we don't have contact details of the person who reported to us, that limits sort of sometimes the sort of actions that we can take. So these are the sort of actions that, and levels of involvement that sort of can occur when a report is made to us. I mentioned before the Elder Abuse Helpline that was doing some work in this space prior to the formation of the Commission. With the establishment of the Commission in July 2019, the Elder Abuse Helpline was brought over and became part of the Commission, and its brief has sort of expanded. So basically it now accepts calls in relation to people with disabilities as well. And so it's our front line, it's our initial point of contact. It does the initial triaging, but it's not just an intake line. 70% of our matters will be dealt with at the helpline level and won't go any further. And the sort of things that they're doing with people are really sort of, people will often phone up and say, look, I'm seeing something, I'm not sure what's going on here. And so, you know, our consultants on the helpline can help a person to clarify what they're seeing, and also help them to sort of start to think about what sort of actions that they can take. because as I said before, it's communities that protect people. It's not commissions. And so invariably, it's actions at the local level which are going to have the most impact for people. So it might be sort of saying to the neighbour, well, yes, you could be sort of, you know, hearing something which is concerning. It could be somebody that's shouting at a family member. These are maybe the steps that you need to take if your concerns increase, so that if you feel that sort of the person's sort of, you know, safety is at immediate risk, then let's help you form a plan about what you're going to do. So, you know, it might be that you phone the police if you have immediate concerns for safety. It may be that you talk to the son or the daughter who doesn't live there about sort of actions that they might take. It may be that you come back to us because you feel that the concerns have escalated. And similarly with service providers or with professionals, it can be about sort of helping them to frame what their response is going to be. And often sort of that will be enough for us to do. So, you know, the caller will sort of go away with a series of actions and sort of you know, a bit of clarity about what they're going to do. The community supports and investigations team is where I sit, and that's where we decide that there's something that needs a bit further, a bit more exploration, a bit, you know, some more actions that need to be taken. And that may be that we sort of, you know, have closer engagement with services. We might pull in other people who haven't been involved. We may, in certain circumstances, we may start an investigation, and in a minute I'll talk about what an investigation looks like. But really, at that point, it's about sort of putting a framework around people if possible, because it's you know, it's eyes on a situation, it's fresh air, as it were, which sort of works best at sort of reducing the risk to people who are experiencing or at risk of abuse, neglect and exploitation. And we're a small office. We obviously hope that we will grow in time, but we clearly can't take on all the work that comes to us. So it's critical that we help you, that we keep you involved at a local level, and that we pull in other people if necessary. And part of that will be sort of, you know, making formal referrals to other services. It might be that sort of through our connections with police, we get police involved if we consider that, you know, that there's a criminal offence which is occurring. Or it might be that we can bring in other services. You'll also notice in that third column that makes reference to the other commissions in this space. Our legislation rather is quite broad. But what it does say is that where there's another oversight body involved, then we leave them to look to cover their domain, so to speak. So when we're talking in the area of older people, you'll obviously be aware of the Aged Care Quality and Safety Commission. If we receive reports in relation to concerns about a service provider or a worker who works with an approved provider, we would sort of refer that to the Aged Care Quality and Safety Commission. Sometimes there's crossover in these matters. So like, for example, if you get someone who's an approved provider, but the concerns are in relation to their engagement with their own family member, that would be a matter for us. So this can be a bit confusing sort of sometimes, but what I would suggest is, if in doubt, give our helpline a call and we'll talk you through where would be best for the matter to sit. And I'll just provide you with some figures here. So in our first full year, we dealt with about 3,000 reports in total. Overwhelmingly, the reports that come to us are in relation to older people, and mostly, as the demographic is, as you'd be aware, they relate to older women. And the reports are usually in relation to psychological abuse and financial abuse. They're the two areas that we have the greatest number of reports to us. Invariably, though, you'll find that sort of it's not just one matter or one form of abuse which a person is experiencing. They're experiencing abuse or neglect, or exploitation, sort of, you know, in varying degrees, sort of in varying aspects of their life. So I don't know, Kevin and Jenny, are there any questions at this time that I could maybe respond to?
Hi, yes, there is at the moment. Thanks, John. There's one. Do you think there should be mandatory reporting in this space, like with child protection legislation?
Yes, that's an interesting sort of issue. I think, and you know, who knows if it goes that way in the end. I think there's arguments for and against mandatory reporting. I think one is that it sort of provides clarity for people. So, you know, there's no ifs and buts, they have to report. I guess if we look at the child protection system, though, the concern could be that we develop to a point where it becomes a matter of you just report and then you step back and you leave it to the protective services to respond. And also, given that the volume of matters that go to child protection, and with a lot of those matters being triaged and no action sort of being considered necessary, the concern would be that we end up in a similar situation. I think sort of the benefit of the system as it is now is that, you know, it does focus on keeping sort of the local service system and informal supports in place. And I'd be concerned if we moved away from that, and that might be a risk with mandatory reporting.
Okay, great. And just another question: what recourse do people have that have had false allegations made against them?
Yes, the legislation itself says that sort of that there are penalties for people who make a a complaint that's not in good faith. So there are protections for you if there are, and potentially there's penalties for you if you don't. I mean, we haven't been in a situation to actually determine sort of, you know, to go down that route with people or for people. We do find often, though, that we won't make a formal finding in a situation, and so it leaves people who maybe are the subject of the allegation feeling quite aggrieved. And yes, that can be difficult, and we will talk people through, you know, the fact, well, we've looked at the situation, we were required to look at it because that's what we're legislated to do. That we're, you know, satisfied that the person themselves, that they're safe, that they've got sort of mechanisms of support around them, and that, you know, that sort of that hopefully in future that support will remain in place. But yes, part of an oversight arrangement like this is that people can feel aggrieved that they've been hardly done by.
And there's another question along the same line. Do you get many reports where one family member may be reporting on another regarding abuse of a parent, but it may reflect family conflict?
Yes, I would, you know, I won't talk in terms of percentages, but I would say a significant proportion of the matters that we deal with where there is family conflict, often it can be difficult to determine sort of, you know, whether a particular person is sort of the perpetrator. And I mean, as you'd be aware, it can be very difficult to unpick those situations. The view that we would take is that sort of what's critical to us, and the legislation sort of in many ways sort of points us to it, is that we need to know what the views of the person are themselves. So while they may be in the middle of all this, you know, what is it that they're saying that they want? What are they saying that they're wanting as sort of the outcome of any interventions that we or anybody else might make? So that's sort of what we would hope to focus on.
Right, thank you. That's all of this stuff.
Maybe before I go into the case studies, there's a few things sort of that I probably sort of could have added to. One was in terms of the investigations that we have, that investigations are very much a small part of what we do. They're the pointy end, and the legislation provided the Commission with certain inquiry and investigative powers which hadn't existed before in New South Wales or even really in other jurisdictions around Australia. And basically what that enables us to do is to seek information from people and to require it if necessary. So we can issue notices to people to meet with us and provide us with information, and also to provide us with access to the person themselves who's at the centre of it, and maybe experiencing abuse, neglect or exploitation. So that's where the powers in our Act lie. They don't enable us to go in and remove a person, and it's a question which we often have. The mechanisms for I guess providing that sort of response are the ones which have always existed or have existed for the last 30 or so years. It's through guardianship legislation and through applications to NCAT. Okay, so I'll move on to the case studies, and these are they're just 3 examples of the sort of scenarios that we get reported to us regularly, and no doubt they're the sort of scenarios which will be familiar to you. So in a situation like this, the initial call would come into to our helpline. The helpline would sort of collect initial information, but also make inquiries of the person who's reporting to try and sort of to drill down to the key risk factors. So, you know, what are the key risks for this person, and also what safeguards are either in place or planned or need to be put in place. So that's very much the focus of our initial response. With a situation like this, what we might be looking at is, you know, concerns about neglect. You know, is that neglect sort of a deliberate in that the son sort of has agreed to take on responsibility for supporting his mother, but hasn't been doing that? Or is it, and often we find this is more the case, that it's just it's neglect by omission rather than by commission. And so the response here would be very much to look and see whether we can sort of get services in place. You know, if Maria has already had a referral to My Aged Care and is already in the system, that would help. But if not, then that's the first step that we would sort of look to try and ensure. At an early point, we'd be trying to sort of seek Maria's views about her situation. So we've had this report. We want to confirm sort of how she actually views the situation. And although, you know, we've got an indication that she's got that she has dementia, it would be our view that it's critical still to find out what her perception of the situation is, what her wishes are, and how those wishes can be worked with. One thing that the Commissioner is very sort of conscious of is that he doesn't want our office to be seen as a default applicant for guardianship orders. Clearly, there will be people who will need guardianship, and in some cases, the Commission will need to be the applicant, but there's a lot of work that can be done with people who are suffering some or experiencing some sort of cognitive impairment that can be done without sort of recourse to a mechanism which, while being protective, does remove their rights as well. So we're very mindful of that. The other issue here that's being identified is around the enduring power of attorney, and we'd be wanting to know sort of what Maria's views are about that. What was, you know, can we get a view about what her intentions were when the enduring power of attorney was granted? Are her wishes still the same? Is there evidence that the enduring power of attorney is being used inappropriately? And unfortunately, having said what I said about guardianship, often the only sort of solution in these sort of matters is to have the enduring power of attorney reviewed at by NCAT. But with Maria's agreement, we would sort of hope to have a discussion with the son about sort of what was going on with his management of her money. And again, we find that sort of in a lot of cases, people are really quite ignorant about what their responsibilities are. So a lot of matters that come to us around sort of where an enduring power of attorney is appointed, there'll be no sort of separation of finances, and so the son would have mixed up his mother's money with his own money. There's no, and can't account for it. And we would hope that we could sort of support him to maybe get his house in order, but if not, then maybe there might be a need to sort of have him replaced as the enduring power of attorney. So let me move on to the next two scenarios, and then maybe we can sort of take questions after that. So here we're looking at a situation where there's care already in place, which is fantastic, and we would be very much wanting to sort of work with and through the existing care arrangements. In terms of the issues that are being identified, there's potentially neglect, possible physical abuse, and we would need to we would make some inquiries around that to determine whether there's a need to get police involved in a matter like this. The injuries to John's upper arms may be because he's being hauled about by Sarah in order to, when she's caring for him, and she's doing a rather ham-fisted job of that, or it could be that he's actually being sort of, subjected to some physical abuse. We have a requirement under our Act that where we receive information which may constitute evidence of an offence, we're obliged to report that to the police. We've got no discretion in that regard. In a situation like this, we might make initial inquiries to try and determine what's going on. But if we feel in the end that the information points to the fact that it's abuse, we would refer that to police, and then we would sort of not make any further inquiries in that regard until they come back and tell us what they're going to do with it. If though it's more in relation to the possibly sort of Sarah not really sort of either knowing how to sort of care for John properly, or she's struggling with sort of providing support, then again the response is a services response. And we would be looking to have a discussion with John, if possible, a frank discussion with Sarah. If we're not able to do that ourselves, then we would be looking at sort of talking through the service providers about how that could occur. And then the final one. So here we would be looking to work very much with the hospital, and would see ourselves as a resource to hospital staff to put protective measures in place for Diane. So to first to sort of to clarify what the issues are, possible sort of neglect, suggestion that that Rachel is subjecting Diane to verbal abuse and possibly psychological abuse. So talking through sort of hospital staff about how the sort of conversation that they could have with Rachel. So yes, very much a resource for the service provider on the ground. In relation to the financial matters, the response there would depend very much on sort of the information that's coming back from Rachel, and also from the hospital. If the indication is that that she's acting inappropriately in accessing her mother's money, then we've got a question there: is this theft? If it's theft, that the police may need to look at it. Is it that there needs to be protective measures put around her? So if she's able to grant a power of attorney, can she do that, and can she be supported to do that? Or is there a need for some formal order, like a financial management order? If we were to conduct an investigation in this situation, we would speak to Diane and ask her for her consent to undertake an investigation. We're obliged to go through a process of seeking consent. The Act says that we must have consent from the person to investigate, and there are only a few exceptions where we can proceed without that consent, and one would be where we're unable to obtain the person's consent, even if there's a process to support them to understand what an investigation is. And secondly, the other reason would be if the concerns are of significant seriousness that we feel that we need to look into it anyway. And that can be in relation to finances. That can be if it's significant amounts of money that are at stake, and if the person is going to be seriously disadvantaged by the actions of the person who is either mismanaging or taking their money. So that's the three scenarios. Clearly, there's many other ways which we may involve or we intervene in matters, but it gives you some taste of the involvement that we may have in a person's situation. So are there any questions?
No, it looks like you've covered everything, Jonathan. There's no questions.
Right, okay. That can either be a good thing or a bad thing. Okay, so I'll just move on to contact details for us. So initial contact should come through the helpline on that 1-800 number there, or through the email. And there you can also see the, oh actually, can you, where's the, yes, there's the, underneath the Commissioner's email address, there's our website address. And I'd encourage you to go and look at that, because it talks in more detail about our role and functions. There's resources on there, including information which has been translated into 26 languages. There's the 2 learning modules. And there's other information as well, so please look at that. So if there's no other questions, I'm done.
Excellent. Thank you very much for that, Jonathan. I can, and it's always the post-lunch session, particularly when we're doing it physical. The beauty of technology is I can confirm to you that there has not been a drop in attendees, so no one previously, just ducking out behind out the back door to potentially do some shopping. But look, that may not stop people doing any online shopping. But I can say you have kept them all interested, Jonathan.
Thanks. Thank you, Kevin.
Thank you very much, Jonathan Havison, our first afternoon presenter. I will introduce, we're a few minutes ahead of time, so we'll keep moving. We do have a break scheduled after the next presentation, so enable you to get out, stretch your legs. But in terms of our next presenter, I'm pleased to introduce her, and very well credentialed presenter as well. Our next session, Lynn has worked at the Wickham Dementia Research and Education Centre at the University of Tasmania since 2014, and she returned there from a lengthy clinical, administrative and academic speech pathology career in the United States. She leads an interprofessional oral health research program focused on older adults in residential care, and also works closely with the Circular Head Aboriginal community in far northwest Tasmania. And this is focused on community-initiated, culturally safe and appropriate approaches to health promotion and wellbeing and dementia risk reduction. To provide this next session on dementia and contributions of speech pathologists and audiologists, I'm pleased to welcome Associate Professor Lynn Goldberg.
Hi, Kevin, it's Jenny. Lynn seems to be running a little bit late. And I can see that Janie Kelly is actually there. Janie, would there be any chance that we could do your presentation now?
Yes, I could do mine now.
Thank you. I'm just going to
see that Lynn is in the attendees, Jenny.
Oh, okay.
Yep.
All right.
So if you just offer the opportunity to make her a presenter, we should be able to get her on, but she is definitely on the line.
Okay. Sorry, everyone, just give me a few minutes.
Hello, can you hear me?
Okay, Lynn, yes, we can. And your presentation is up?
Great. Just trying to minimize a few things here. So can you see the whole, is the slide on the whole screen or just part way?
Oh, it appears the whole screen, the whole slide is showing.
Okay. Well, thank you. I just wanted to say thanks to the organisers too, because I've been here all day and it's been a fascinating day, and I'm looking forward to the next series of presenters. I also want to mention that even though I'm going to focus on audiologists and speech pathologists, I want to stress that care is always a team effort. So there are physiotherapists, occupational therapists, dietitians, pharmacists, doctors, nurses, carers, and of course, family and friends. And now I'm having trouble advancing my slide. Here we go. But before I begin, as a reflection of the deep history and culture of this island now known as Tasmania, and in the spirit of reconciliation, I acknowledge the Lutruwita nations, the traditional owners and custodians of the land from which I'm speaking, and I pay my respects to their elders, past and present. So I'd ask us to think about taking a strengths-based approach as we think about intervention. And it was lovely listening to Jonathan's comments earlier about the importance of hearing from people with dementia. I just am such a proponent of understanding and developing a really solid base from which to work with folks with dementia. So we need to understand them, interact, have fun with them, and just know who they are as people, what they've done in their lives, what they continue to enjoy to do, and wrap intervention around that. So they're people first and the condition of dementia coming in second. And I think through this, and I'm sure you're all on the same page as me, wanting to facilitate respect, dignity, autonomy, choice, comfort, and health and well-being. We need folks with dementia to be as healthy and strong as possible so that the work that we do has the best effect. So it's critical to optimize people's ability to hear, to see, to touch, particularly if we're relying on nonverbal methods of communication. To smell, we all know that the sense of smell can often be a predictor of certain types of dementia, and it's having a sense of smell for the lovely aromas in life as well as the ones that tell us there's danger is really important. And we must have a pain-free mouth to be able to talk, to socialize, to eat and swallow. So for those of you who don't think about hearing too often, let's see if I can work this cursor. Can you see my little arrow? Anyway, sound comes in the external auditory canal here, goes through the middle ear and then into the inner ear. And it's really important to think that it doesn't stop there. It goes into the lower part of the brain, brainstem, and then travels up on both sides of the brain to important areas for hearing. And it's not just to hear, it's to process different types of sounds. So to be able to determine if there's a car coming in the street, or if there's a dog barking, or if there's a person talking to you. And that's connected as well to higher levels of the brain that allow us to process information, to store it, to retrieve it, to associate it. So hearing is pivotal in that sense. It's important too to remember that the hearing comes from the 8th cranial nerve, and it's got two really important sections. And one is for hearing and one is for balance, or called vestibular function. So both of these areas need to be paid attention to. So we need to make sure this auditory vestibular system is functioning as well as possible, particularly as people age and particularly for people with dementia. So we'd advocate a regular check of hearing and balance by an audiologist, and this could be a part of regular healthcare. And this obviously is done in connection, close work with physiotherapists if people are having difficulty with falling. We don't want people to fall, but it can be related to balance issues related to this auditory and vestibular function. So working closely with physiotherapists is certainly crucial. It's also important to understand which medications have been prescribed for people with dementia, because some can affect balance and some also can dry the mouth, irritate the gastrointestinal tract. So making people feel unwell or uncomfortable and less interested in eating and socializing. Just wanted to make this point about hearing loss and depression being related. There's been a lot of work underway looking at ways in which dementia risk can be reduced, but understanding the links between many of the factors is really important for people, even if they've been diagnosed with dementia. So you can see here just the fact that almost 45% of adults 60 to 69 live with hearing loss, and it's just critically important that that be recognized and well treated, well managed, and how the prevalence goes up to 90% for adults 80 years and over. So there have been two theories. That one, that if untreated, hearing loss is a chronic stressor that may worsen existing difficulties associated with psychosocial and functional abilities. And the other theory is that untreated hearing loss could be associated with, or a reason for, degeneration of neurological mechanisms. So important parts of the brain that are associated with auditory perception and mood. And these parts of the brain are in the limbic system, the frontal cortex, and the auditory cortex. And so these researchers in Australia, Blake Lawrence and his colleagues, have done this analysis of lots and lots of studies. You see here 35 studies, but 147,000 participants, and actually found support for both of these theories. So the take-home message being that hearing loss needs to be identified and well managed. So if it's not treated well, it can compound the effects of depression. And it seems as if it can compound degeneration of the brain, particularly those areas needed for auditory perception and cognitive function. So it's a really, really important issue to pay attention to for folks with dementia. Similarly, although the points in this slide relate more to issues of trying to reduce dementia risk and focusing on hypertension or high blood pressure, this also applies to older folk. So we need to make sure that if they have hypertension, that it's well managed, right? Because we now know from solid evidence that it is related to hearing impairment that's acquired in midlife or later life. And this seems to be related to how hypertension affects blood flow. We know that hypertension affects blood flow to the body and brain, but we've got evidence now that it affects blood flow to the inner ear. So it changes the pressure of oxygen that we need in order to hear well. And it damages the cochlea. And over on the schematic on the right, you can see the shell shape of the cochlea, and outlined in those red dots is the area that hypertension is thought to affect. The other important point is that if a person continues to smoke, smoking has these toxic effects. So it compounds the consequences of hypertension. So you get these increased levels of carboxyhemoglobin and nicotine that restrict blood flow to the cochlea. So that further increases the blood pressure. So things that we just don't want to have happen. There is other important information to show us that racism is associated with hypertension. This is a very important thing to keep in mind. Obesity, particularly abdominal obesity, is also significantly associated with both hearing impairment and hypertension. Again, showing the link between the effects of chronic inflammatory disease and this cardiovascular disease that might be present or increasingly apparent. So just really important things to keep in mind in terms of trying to keep folks with dementia as healthy as possible. And if these comorbid health conditions occur, having them well treated. We want somebody just to be well and healthy. Tinnitus is another issue. This is the ringing in the ear that people, as they age, may experience. So it's true for people with dementia, and it seems related to heart problems, and that brings us back to this interrupted blood flow. So we also know that people with tinnitus have difficulty with memory because of this noise that's constant in the ear. It's hard to pay attention, hard to concentrate. So it's really important to identify if this is an issue for folks and then to work on some techniques that may help. We can't make the tinnitus go away, but there are some interesting strategies, particularly mindfulness training. This, as you see, based on meditation techniques, that can be very, very effective. And there are audiologists who specialize in this. Another interesting issue is Tai Chi, and this is, as you undoubtedly know, a physical activity with choreographed movement patterns that incorporate cognitive, social, and meditation components, and therefore learning. And there's a very interesting work by Lim and his colleagues recently, looking again at a review of published studies, showing that it can have an effect on cognitive function. The effect doesn't last, so it brings back the importance of, if Tai Chi is an enjoyable activity for folks, then it needs to be a regular part of life. There's also evidence that Tai Chi can increase balance, so therefore help reduce the risk of falls, increase visuospatial skills, increase memory, and that's been measured by people with dementia reporting less complaints of memory loss, which is a very nice thing. Can decrease blood pressure, increase breathing capacity, which is really important for life, but also for swallowing, as I'll get to in a little bit. Increase emotional well-being. So there aren't yet any really controlled studies of the effect of Tai Chi on tinnitus, but it's certainly worth considering. And it just brings it back that with any approach, we need to know the person with whom we're working, what they enjoy, and build from there. As you see in the picture, it's also adaptable. We don't have to be standing. So people who can't stand easily, at least at a particular point, can certainly benefit from Tai Chi from a sitting position. So hearing aids. I'm trying to think who said it this morning, that if hearing aids are needed, they need to be worn. It's just so true. There are many different types, and obviously there are different costs, but it's important to touch base to see an audiologist and see one regularly. Even if no hearing loss is identified, it's very valuable to have a baseline hearing function established. So an audiologist can complete the testing and advise on the best type of a hearing aid. And those of us who provide care to, or work with people or live with people with dementia need to know how to insert hearing aids. We need to know how to replace batteries, and we need to make sure that the hearing aids are working. I think too, there's an important issue of taking time for people to adjust to wearing a hearing aid. It's not easy and they're never perfect, but they really are important if they're needed. And this is again where meditative approaches may come in terms of the just relaxing, thinking of the benefits of the hearing aid and becoming more accustomed to wearing them. It's important, I think, too, to stress to folk who haven't had their hearing tested that the hearing testing itself is not painful, but we do need to be alert to any pain or discomfort in the ear. And if you're working with someone who wears hearing aids and doesn't want to be wearing them, it's really important to look and see if there is an inflammation in the ear canal, or if there's something going on where the presence of the hearing aid is not making things easy. And again, that's where you would go and see your audiologists and figure out what's gone wrong. So noise, there's lots of lovely noise in the environment, good and bad. And I think we need to be guided by each person with dementia as to what kind and amount of environmental noise they enjoy and the amount that they can tolerate. Some people like being in noisy social situations, others don't. Some people who know they have difficulty with their hearing but don't want to admit it, we need to take our cues from them as to how we can accommodate that. And I'm thinking here of my father, who died last year at the age of 93. He had vascular dementia, and I lived with him for the last year of his life, and it was very interesting to have a clinical perspective at work and different perspective at home. He declared he'd been an engineer, so he knew he had a high frequency hearing loss that often comes with working with machinery. But he declared that he didn't have any other hearing problems. But after he died, we found his audiogram that showed a sizable loss in his right ear. But it was pretty obvious to everybody that he had difficulty hearing, especially in social situations. And so, you know, you figure out where it's best for him to sit, which restaurants might be better places not to go because they're so noisy. But, you know, it's an interesting and sometimes enjoyable problem-solving exercises to where the person wants to go and how we can accommodate any issues that need to. Audiologists also are very valuable folks to be able to assess indoor environments for noise levels, and they can advise ways to dampen any unwanted sound in indoor situations. So I'm coming now, switching gears to speech pathology. I wonder if anybody wants to, if there are any questions, I'm happy to give you a bit of a break at the moment and address those.
Hi, Lynn. No, at the moment, there's no questions on the screen.
So speech pathologists facilitate communication. And this is understanding language, expressing language, and that expression can be verbal or non-verbal. And also facilitating safe swallowing. So speech pathologists can specialize in many different areas, and it was very valuable listening to Rebecca Ahmed this morning talking about language issues in frontotemporal dementia. My area is in oral health and swallowing, so you're going to see more slides on that today. And I became interested in this because I was, became fascinated at the link between swallowing difficulty and aspiration pneumonia. And we know that aspiration pneumonia is one of the most frequent reasons for people living in residential care to end up in hospital. And sometimes it becomes a very nasty circle. People go to hospital and get treated, they go home or back to residential care, but are still very vulnerable to redeveloping the aspiration pneumonia, so their frailty increases and things usually don't end well. So speech pathologists can really help you understand how a person is able to move their mouth, their throat, how well their breathing is coordinated with swallowing, as well as how well the brain is functioning for cognitive and language tasks. So then we work in partnership with each person and their family or carers to figure out how best to assist. There we go. So such an important issue, having a healthy mouth and ability to swallow. I think we take it for granted, but we really want people to look like the gentleman on the left of the slide, happy, pain-free mouth, rather than the lady next to him who's tired, underweight, not interested in eating, and we wonder if that tracks back to a lot of difficulties with oral health. We recently completed a project in residential care where we screened people's oral health as well as their nutritional status and their ability to swallow and their perception of their quality of life. And then we've implemented evidence-based oral care, which was really up to 2 minutes of teeth cleaning at least twice a day and daily cleaning of dentures. We tried to keep things simple so that it was doable. And then we measured the effects of the screening after 3 months and after 6 months. We had significant improvements in people who need to be referred to see a dentist. And I'm sure you all know that getting dentists into residential care situations is often difficult. And it's also difficult sometimes to have people in residential care be able to go to see a dentist in the general community. So clearly, you know, I'm advocating for having people who've been diagnosed with dementia continue to see a dentist regularly. But if people move into residential care, then there are people in that situation who can be of enormous help. And so we were working, we is our team of dentists, speech pathologists, dietitian, and pharmacists, and we were working with nurses and carers to implement this program of daily oral care. And it turned out to be, we had a few bumps early on, but it turned out to be fairly straightforward. And carers in particular, people who provide direct care, were just fascinated to learn more about the mouth and how to identify issues that needed to either result in referral or certainly be attended to. And with the schematic on the right, I just wanted to point out, as you look down at the larynx and at the this laryngeal opening here, this is the airway. So we breathe in and the air comes from the lungs and up and through the mouth, but this is the pathway of food down to the stomach. So it's critically important around this epiglottis and laryngeal opening that muscles work the way they're supposed to, so that the airway is blocked off when we eat and is open for when we breathe. And this becomes a problem, this incoordination becomes a problem quite often for folks with dementia. You can also see how big the tongue is. We sometimes don't think about how big the tongue is in terms of its musculature and how important it is as a driver for an effective swallow. And speech pathologists can measure tongue strength. And then there are exercises that can be done to increase tongue strength. So sometimes you get into conversations with people as to, well, this person's got dementia, is there any reason for us to get involved in rehabilitation? But we have some substantive evidence to answer that question with yes, there's every reason. Sorry to show this to you after lunch, but we do know that people, particularly folks in residential care, which is really sad, develop seriously bad problems with teeth. And more older people these days are keeping their teeth rather than having them removed and replaced with dentures. So teeth can wear out with age, but you can see people can experience soft tissue trauma, obviously associated with pain. There are changes in taste and oral sensation, chewing problems, which then move on to problems maintaining weight and being well nourished. Teeth can fracture. Food can be retained, and that sets up infection possibilities. Same with plaque, and then cavities. So when you look at these nasty pictures, think about how easy it is for once there's sort of a hole in the mucosa in the mouth, how infections, especially if food is left there and not cleaned away. So infections can be established, but then because the infection can be blood-borne, taken through the blood into other parts of the body as well as the brain. So other parts of the body can include the heart, and then obviously the brain. So there are a lot of people working on looking at potential links between very poor oral health and brain dysfunction, particularly in folks with dementia. You know, we're all about trying to keep people with dementia as healthy body-wise, but also brain-wise. So even if we know that, well, we do know this is a progressive disease, but we want to slow the progression down as much as we possibly can. We need to be unafraid to look in the mouth and to ask people to take their dentures out so we can have a good look. And what we found with our project was that sometimes carers who are obviously time poor, but how important it is, because you can look in a person's mouth, person wearing dentures, and think that there's nothing wrong. But we found some very interesting things. There were, and I think also too, older people sometimes don't want to be a bother, and so they wouldn't necessarily speak up if something was amiss. We had a broken denture that had been repaired with glue, and the glue had set up an infection on the palate. Yes, just things that people shouldn't have to put up with that led to a lot of pain. And when we heard this morning Sue's presentation about pain can often being at the root of somebody's unexpected behaviour, we need to really look and see, because keeping the mouth healthy is such a straightforward thing to do to stop unwanted consequences. So what you see here in this candidiasis is a picture of this yeast infection in the esophagus. So you can imagine when people are swallowing on top of this very painful infection, how painful that is, or how much they don't want to do it, so they stop eating. You can see the thrush of the candidiasis around the lady's lips, the corners of the mouth. Look at this cracked, dry, burning tongue. Who would want to talk or eat or do anything that touched the tongue in that situation? In the photos below, you can see the infection on the surface of the tongue and on the uvula. So it's important to understand if we do see an infection in the mouth, whether it's on the lips or on the tongue or other structures in the mouth, the mouth just doesn't stop. It's connected to lots of other structures on the way to the lungs and the stomach. And so it's really important to be alert to any infections that we see in the mouth. People who have diabetes that's not well controlled might have large amounts of sugar in their saliva that increases the growth of infections like Candida. Yeah, so oral health examinations are just so important. I should say the nice thing about our project was that it resulted in a change of policy and practice. Where I was working, the organisation hadn't had a system in place where when adults came into the residential care centre, their oral health was screened or their nutritional health was screened. We had information from ACAT exams perhaps, but quite often those exams had been done months earlier. So there was a gap in the knowledge base, and you couldn't make a presumption that what had turned up on ACAT was now the same. So after our study, the owners of the business, I guess, recognised the value of this screening. So it's now in place that people moving into this residential care community are screened for both oral health and nutritional health when they come in, and these screenings are done on a regular basis throughout the year. So when we suspect someone with having swallowing problems, there are two ways we can have a look at this. And this is an interesting issue for speech pathologists, because quite often people don't have ready access to these instrumental procedures, but they are available And it's really important to try and get a visual picture of what's going on if you think that there's a swallowing problem. So this is a video fluoro swallowing study or a modified barium swallowing study. So it involves radiation. So there's protective measures necessary there, and for that reason, it is usually limited to 3 to 5 minutes and just performed as needed. But you can see in the slides from A through F, the black shading is the bolus, the food or liquid that's been taken in. And so you can see it change from A to B as it travels further down the system. So here in C, and then in D where it's entering the esophagus, continuing in E, and then all gone in F. And so we get a really nice idea of whether there's residue, and if there's residue, where is it? And is it a danger? So we're looking particularly for where the two tubes, if you will, divide. We want to see, we don't want to see any residue around the opening to the larynx, because that's a problem area, but that's quite frequently what we do see. Here's the other version, and this is fiber optic evaluation of swallowing, or FEES. And I found this quite, people with dementia quite ready, willing to undertake this procedure, as long as we take the time to explain what's going to happen. So this doesn't involve radiation, so it can be done for a long time. It's portable, so it can be done at bedside or in the home. Because this tube, this fiber optic tube, goes through the nose, the mouth is free, and so the person can continue to talk to us. We can ask them to do some exercises where we can have a look at the vocal folds, which you see in the picture. So it's often used as to get an idea of the health of the voice as well, or the larynx. And while we don't see the complete swallowing picture that we do on a modified barium swallow, you can see here, I don't quite know why we color it. Well, we color liquids green, foods and liquids green, so that we can see them against the pinkness of the mucosa. But it does look an interesting color, I admit. So you can see with the epiglottis, on a swallow, the epiglottis will close over the vocal folds and protect them. And then it flips back again, and you can have a look to see if a lot of residue is there around the opening to the vocal folds. And if it is, we get an idea of what we need to do in terms of intervention. I wanted to make a point here just to draw your attention to this red circle. I mentioned before how important breathing is. And when, as healthy adults, we have this breathing pattern of exhale, swallow, exhale. You might think that you might breathe out, swallow, and then breathe in. But we continue to breathe out for a particular reason, and that's that if there's any food or any substance like that around the entrance to the airway, by continuing to breathe out, there's less danger of inhaling it into the lungs. So as people with dementia become frail, either for other chronic health conditions or just because they're in generally poor health, this ability to coordinate breathing out, swallowing, continuing to breathe out is compromised. So if you just look within that red circle, you can see here this breathing out. Here's where breathing stops on a swallow as a completely protective measure. You don't want to be breathing while you're trying to swallow food to the esophagus and stomach. And then we continue to breathe out before we breathe in again. So these are important issues that we have good instrumental techniques to document so that we get a really good idea of what a person's ability is and if there are any danger or weakness in the respiratory system. As I mentioned earlier, I'm really concerned about folks who do develop aspiration pneumonia, and it is one of the most common reasons for people in residential care to be hospitalized. So we want adults to be able to cough if they need to get rid of food or liquid around the airway, and we all do that. But we also want to be alert to whether there's a problem with frequent coughing and changes in voice quality. Sometimes people, especially after drinking or eating, have what we call a wet sounding voice, and this can indicate that there is stuff around the entrance to the airway. Also, adults, especially frail older adults, can aspirate silently so that they can take food and liquid into the lungs, but they don't cough. And this, you can imagine how dangerous this is and how then chest infections result, and people wonder why. And actually that's how I ended up being involved in or invited in to start the study, the oral health study, because this particular residential care community had been cited on an accreditation visit for a high number of residents with chest infections. And we were looking to see, well, what's going on here and how can we address this? And indeed, part of our results were a significant decrease in the number of adults with chest infections and the number of folks who ended up having to go to the hospital. I always hope people don't have to have their food reduced in texture or their liquids increased in texture, but there are some people who do have difficulty with swallowing thin liquids and regular foods safely. And for those folks, we need to be really careful in how we modify food textures and increase the texture of liquids. And the other really, really important thing to say is if you're working with people who are eating modified foods or drinking modified liquids, please review their ability, their swallowing ability on a pretty regular basis. Work with the speech pathologist to do this, because it's important that we not think that just because someone needed detexturized food at one point that it's going to stay that way. We always need to keep modified foods and liquids as close to normal texture as possible. You're probably familiar with a physician, Dr. Joseph Ibrahim, who talks about the dignity of risk, and this applies to all sorts of aspects of life, certainly applies to eating. And this is again where we need to work with folks in terms of what do they like to eat, what do they like to drink, and have good discussions about the risks that may be entailed by keeping foods as normal a texture as possible or liquids as thin and enjoyable as possible. Because the difficulty with modifying foods and liquids is that even though we think that we're making it safer for a person to swallow because the modification slows down the movement of the food or the liquid in the mouth and then through to the stomach. But the trouble is it changes, those modifications change the palatability of the food and liquid, they change the appearance of it, they change the way it feels in the mouth, and often they make it more difficult. You've got to put more effort into eating or drinking these foods, and people then don't eat and drink them. So they eat less or they drink less and they lose weight and they become dehydrated, and that sets them up for continued infections and ill health. You may also be familiar with Peter Morgan-Jones, who's written these two books, Don't Give Me Eggs That Bounce, and it's all about the food, not the fork. I'm presuming he still travels around and talks about these books, but they're marvelous books in terms of recipes that you and I, who don't have any swallowing difficulties, would be happy to make and happy to look at and happy to eat. The foods are beautifully presented. Even down you see those gin and tonic lollipops. So just because somebody has been identified as needing to have their foods or liquids modified doesn't mean that they can't have food that's well presented and tastes good. I did want to make a point about tube feeding. And this is when, obviously, when people with dementia receive their nutrition via a tube. So the tube can either be through the nose to the stomach or directly into the stomach, as you see there with this PEG tube. Even when people are receiving nutrition by tube, it's really, really important to keep their mouth healthy, keep it stimulated and healthy. And this is also where dignity of risk comes in terms of what foods even if you put the food in the mouth for enjoyment and then remove the food because swallowing is so difficult. It's just important to keep the mouth clean and fresh, feeling good and stimulated as appropriately as possible. But as you see in the note at the bottom of the slides, when people are entering the last stages of the condition of dementia, there is weight loss and there is malnutrition, but these are considered hallmarks of this terminal phase. And there is evidence to show that PEG tube placement does not help at this stage. Here's the most recent article, this one published in February 2021. And you can see, again, it's a systematic review looking carefully at loads of papers that have been presented on the issue of tube feeding. But you can see how PEG tube feeding did not promote length of life. It increased the risk of aspiration pneumonia. So people often think, oh, if a tube is placed, the risk of aspiration pneumonia goes down. That's not so. It increased pressure sores, quite often because people were restrained in place. It increased urine and fecal incontinence, which just is not what we want to do to people. And there is this possibility of restraint, physical or chemical, so that the person is still and the tube is not disturbed. But that in and itself can lead to tube-related complications. So there's careful measurement of nutritional status, and again, documentation that PEG tube feeding did not improve nutritional status. But the really poignant comment was that many families and the adults with dementia receive little to no information to assist them in making decisions. And this is particularly true regarding cultural and spiritual needs. So we all have a lot of work to do, especially speech pathologists, because we need to know this recent literature, the good evidence, so that people, this will be a family decision as to whether to have a tube placed. But people need to be able to make this decision on the basis of the best available evidence. So just a point again about communication, how it can be verbal and non-verbal. But it's got to be wrapped around what's enjoyable to people. It's got to be meaningful, active, authentic, and functional. I think there are many, many different situations throughout the day in which communication can really be facilitated. There are things like these 10 top tips you can find on Google. But I think this is where it comes back to knowing the person with whom we're working. Reminiscence is an evidence-based technique that can really be useful just in terms of understanding what this person loved to do, achieved, etc. when they were younger. Just in having these conversations and setting up reminiscence books, I found out so many fascinating things. I worked with a couple who had dementia and who were now in residential care, but it turned out they discovered rayon. People who published books, people who invented interesting farming techniques. It's all there in terms of just getting to know older folk. I do think we need to pay attention, those of us who are providing therapy and often asking people to fill in forms to make sure the directions on the form are as clear as possible so that folks with dementia can hopefully fill out their own forms or take part in filling out the forms. There's good evidence about memory aids. There are just lots of things. I've got this picture of a person getting dressed because that's a marvelous opportunity for people to, or speech pathologists to work on issues that might be needed in terms of just the actual nice daily function of getting dressed in the morning. What would you like to put on? What colour socks? The brown belt or the black belt. Just facilitating choice and autonomy and dignity, but you're wrapping it around a very valuable language activity if that's what's needed. We talked, I think Sue mentioned this morning and even showed this same slide of a lady enjoying music. There is some evidence to show that it improves cognitive function and therefore quality of life and has a positive effect on decreasing depression. I just recently read a systematic review of the effects of dance, and the answer was no, it has no effect on cognition. But I think we have to think bigger. You know, this is, if people enjoy dancing, then we need to think about that joy. Can we bring the dancing back so that it is part of everyday life, or once or twice a week or something like this, so that it's just part of an enjoyable day, and that in itself will lead to really interesting and valuable things in terms of improving communication. I'm just about out of time here. Here we go. I was going to tell you about an anecdote, but I'll save it for later. This is an interesting article published last year, very valuable article because it asked people with dementia about what they wanted. So many studies are great, but they forget to ask people with dementia, how was it for you? You know, do you agree with these outcomes? So these folks with dementia, here's what they wanted to see. Here's what's important to them, right? Having good relationships with people, being able to communicate, feeling safe and secure. You can see the list. Being able to do things that you enjoy and want to keep doing, keeping interested in things you like, being aware of your surroundings, indoors and outdoors, being able to find your way around, clean and comfortable, not falling, being able to see, hear and understand, feeling able to keep your identity and being able to have a laugh with other people. So communication is inherent in all of these things, and this is where speech pathologists can work, as I said before, with everybody else on the team to make sure that we can have these outcomes for folks with dementia. And in wrapping up, I just wanted to talk to you about this wonderful work that's going on. I have the good fortune to be involved in this team. Kate Smith is an occupational therapist at the University of Western Australia and developed this quality of life tool. Believe it or not, there was not, until her work, there was not a quality of life tool for Indigenous peoples anywhere in the world. So Kate is the first one to do this, and she has now validated it with people in urban settings, and we're in the process of validating it for people in rural and remote Aboriginal and Torres Strait Islander settings. And I smile because it was interesting to have some people realise that we do indeed have some Aboriginal communities in remote and rural areas of Tasmania, and I'm lucky to work with them. So you can see here the 12 factors that came out of Kate's work, 12 factors that are important for having a good spirit, right? And these marvelous quotes about the need for having a spirit that is healthy and what needs to be done in terms of connecting. And I would strongly suggest that this good spirit, good life approach, while it's invaluable for Aboriginal and Torres Strait Islander folks, it needs to be considered also by people who aren't from those communities, because there are so many parallels, I would think, when you look at these 12 factors as to what's so important, how they're so important to making anybody with dementia feel whole and respected and able to live a good life. So I'll leave it there. Thank you very, very much for listening to all of this.
Thanks so much there, Lynn. Brace yourself, there's quite a few questions now. I'll start with Jenny. So Jenny asked you, what are your thoughts on the quality of hearing aids that are covered by the government subsidy?
I appreciate the question, but I'm not the person to answer. I would refer you to an audiologist, and there are audiologists who specialise in working with folks with dementia. So contact Hearing Australia and ask to be referred to someone who specialises in work with folks with dementia. I know there are differences in quality and cost. It's an issue.
Chris says, what is the relationship between racism and hypertension?
Yeah, it's a really interesting question. There's been a terrific paper recently put out by the Lowinger Institute in Melbourne. If a person is on the receiving end of racism, obviously there are internal issues that result in higher blood pressure. And higher blood pressure, as we know, is not what we want to have because it has ramifications throughout the body and brain. So it can exacerbate existing health conditions. It doesn't do nice things to the brain. So it is good to know that there is evidence to show that racism is connected or associated with high blood pressure, and to then work on ways in which people aren't the recipients of racism.
Great, thanks for that. Lauren says there is a really great app called Easy Talk Lite for Android or similar iPhones, or similar for iPhones, that recognises your speech and puts it straight away in text on your phone. A great, faster alternative for patients that need things written down in a notebook. This is not a question, just a great tip that she learnt at a recent forum.
Fabulous. Yeah, I learnt too. Thank you.
Leanne states, fantastic presentation, so educational. Next question is, thank you, Lynn. Great presentation to raise awareness on the impact of hearing loss, speech and swallowing issues and oral health. Also important issues for staff to be aware of. Speech pathologists play a varied and important role in assisting people living with dementia, with swallowing problems and expressing themselves and giving them activities to do. I think they are often underutilised or may not be accessible. I'll just get that through. Accessible in some smaller centres. That's Kate Doyle.
Yeah, it's too bad, I think, and I don't mean to make big sort of generalisations, but it does seem that speech pathologists are called upon when something has happened. It's much better if we're called upon to be proactive, and there are so many things to be proactive about in terms of working with folks with dementia.
I just say there, I work with refugees in Armidale here, the Yazidis, and one thing we're finding really frustrating is the lack of TIS for, or translating interpreted services for allied health, which is something we're really working on trying to get to happen, because we just hit a brick wall the minute we need a physio, OT, speech pathologist. Sandra asks, thanks, or says, thanks so much, very interesting. Are PEG tubes becoming increasingly out of use across the board in a variety of conditions?
I was just talking today about their placement for people at the end of life, and we do know that there's good evidence, solid evidence to show that's not advisable, but it's a very hard decision. It just requires care and time to have the family members especially understand, because a lot of times people react by thinking that we're withholding nourishment and therefore hastening death, but the evidence doesn't suggest that. But in other situations, I don't know. So really, I'm just being hopefully trying to be careful in terms of just referring to people at the end of life. NG tubes, you know, are clearly used when often when there's a short, acute or an issue of short standing, so that there's the understanding that the tube will be removed when the issue has been resolved. But that's not the case with PEG tube placement for people at the end stage of life.
Janelle Gilman makes the comment, mouth care matters. Another question, Steph's asking, hi Lynn, with people with significant cognitive impairment, but who obviously do not like texture modified food and thickened fluids, how do you go about implementing dignity of risk, i.e. is this something that needs to be discussed with the person's guardian or EPOA?
Yes, everybody needs to be involved in it. And I've had invaluable help from chefs, you know, the people who people who make this wonderful food, in terms of what we need to do to make food safer or to gradually back off on the increased texture or decreased texture. It's got to be a team decision, including the person with dementia. Oh, sorry, I didn't realize you couldn't see me. Go.
I do like the idea of the gin and tonic ice blocks. I'll tell that one to my kids. That's it for questions.
Okay, and I know this issue of mold, they're so essential and they're so difficult sometimes, but it's everything is what we need to strive for, just to make life as great, as quality filled as possible for people with dementia.
I'll pass you back to Kevin. Thank you.
Okay.
Thanks very much, Lynn, and thank you for attending throughout the day and being able to participate as well. Presentation was very well received given the amount of positive feedback that's come through. And as a bonus, you've gone to time as well. So full thumbs up for that as well, Lynn. We are going to take a break now before we get into the final session for today. So we'll reconvene at 2:30 when we look forward to a triple threat to end proceedings for the New England Dementia Forum. So we'll see you back here at 2:30.
Cooperation makes it happen. Cooperation, working together. Dig it. Cooperation makes it happen. Cooperation, working together. I saw these crazy dudes and they were out on the street. They were clearing out the empty lot and making it neat. I said, man, is this cool? What you trying to do? They said, making a garden for me and for you. They said, hey man, join us. Come on, let's go. Together we can make a pretty garden grow.
I'll dig a hole,
And I'll plant a seed.
and we can add the water that'll grow when things need.
Cooperation makes it happen. Cooperation, working together. Dig it. Cooperation makes it happen. Cooperation, working together. Now we friends were on the corner hanging out. I said, hey, you can hang around these garbage cans some other day. They said, man, is this cool? What you trying to do? I said, make a street garden for me and for you. I said, hey, cats, join us. Come on, let's go. We'll all cooperate and make a garden grow. You dig a hole, and I'll plant a seed, and we will add the water that'll grow when things need. Cooperation makes it happen. Cooperation, working together. Dig it. Cooperation makes it happen. Cooperation, working together. Now we watch our garden grow and we come back every day. And the people in our neighborhood come round and say,
Hey man, this is cool. Tell us what we can do to keep this pretty garden here for me and for you. We all say, hey, join us, come on, dig the seed. We'll all cooperate and keep our garden green.
You trim the leaves,
And you pull the weeds.
and I will add the water that'll grow when things need.
cooperation makes it happen. Cooperation, working together. Dig it. Cooperation makes it happen. Cooperation, working together. Dig it. Cooperation makes it happen. Cooperation, working together. Dig it. Cooperation
And welcome back, everybody, for the final session of this afternoon, a triple treat allied health bundle to wrap up proceedings for today. And the first presenter of this allied health bundle is Janie Kelly. She is the H&E LHD clinical nurse consultant, continence, and is presenting on the cost of continence. Now, Janie has worked as a midwife for 16 years, a child and family health nurse, community nurse, and clinical trials coordinator before stepping into the role of a continence nurse 8 years ago. It's a pleasure to have you present, Janie, and I'll let you take it away.
Thank you very much, Kevin, for the introduction. I'd just like to acknowledge the custodians of the land on which I'm speaking today, and pay my respects to elders past, present and emerging, and acknowledge all Aboriginal participants today. And say that I have really enjoyed the previous presentations, and to say thank you for inviting me to participate, and thank you to everyone for hanging in there for the long haul this afternoon. Alrighty, so now I just need to do that. Aha. Okay. So I'll be briefly touching on each of these points and acknowledging the cost of incontinence is more than just financial. There are 21 steps to the toileting process, highlighting that going to the toilet, an activity that we all may take for granted until there is an issue, is a complex activity. Just one or two missing steps can sabotage continence. Incontinence is an example of how a reduction in the enjoyment of life, withdrawal, reduced mobility impacts on an activity of everyday living. Acknowledging and managing toileting incidents when they first start happening is important. So a practical example is a carer asking the man in their life to start sitting to pass urine, preventing the spray or dribbling that can cause a mess for the carer and potential slips or falls at the toilet. Anecdotally, more men seem to present denying incontinence than women. Perhaps, as one wife explained, wearing pads has always been a woman's problem. Different parts of the brain experiencing changes helps to explain why people experience different problems with steps within the toileting process and why not all strategies work for all people. For example, there's the person who unsuccessfully manages a urinary or fecal accident, wraps their wet or soiled clothes and puts them at the back of a drawer to deal with later, but forgets. Changes to the parietal lobe may interfere with finding the way to the toilet and not recognising the toilet. The obvious example is a man passing urine in a waste paper basket. There may be difficulty in depth perception, the person seeming to fall onto the toilet or not sitting on the seat properly. Colour perception changes may make it difficult to differentiate between pale walls, pale floors, a pale toilet, and a pale toilet seat. Floor surface changes may create confusion or fear, not being able to step from carpet to tiles. A rug may resemble a large pool of water or a sharp drop. Frontal lobe changes may mean the person does not recognise bladder or bowel sensations as an urge, not recognising they need to use the toilet, resulting in incontinence. Not making any attempt to find the toilet may also be related to lack of motivation, depression, or distraction. Being easily distracted, the person may not realise they have not finished on the toilet and stand, the carer having to manage urine or fecal incontinence while the person starts moving away from the toilet. This is a really difficult behaviour for carers to manage. Same-sex carers may be more appropriate depending on disinhibition. With assistance, Some steps to the toileting process may be restored. Timed toileting may be useful, given encouragement every 2 to 4 hours based on the person's own habits may reduce the number of accidents. It is important to check the person has used the toilet and not forgotten or become distracted. Prompting needs to be done sensitively to avoid patronising or annoying the person living with dementia. Look discreetly for signs such as fidgeting, pacing, getting up and down, a flushed face, or pulling at clothes. Skincare and treatment of excoriation with barrier cream cloths containing dimethicone relieves the pain of incontinence-associated dermatitis, or IAD. IAD is sometimes confused with pressure injury or fungal infection. We know that fecal incontinence is a major reason for admissions to residential aged care facilities. It's very difficult for family carers to manage. And I'm thinking of the perceived cost of loss of dignity on behalf of the person living with dementia. Time, experience, knowledge and skills may determine if successful toileting can be maintained. Being aware of resources available from the Continence Foundation of Australia, dementia support organisations, the Carer Gateway can be very useful and reassuring. It can be hard as a carer not to get angry or upset, and talking with someone can help. It's important to exclude other causes for incontinence. Incontinence is not an inevitable consequence of dementia. A person may have been prescribed an anticholinergic medication, such as oxybutynin, also known as ditropan, for long-standing urinary incontinence sometime in the past, and it's well known these medications can result in cognitive impairment and they need to be ceased. Urinary tract infections need to be treated. UTIs can cause severe confusion, but I'm not spending time discussing delirium today. Benign prostatic hyperplasia or prostate enlargement can cause urinary incontinence, but it is treatable. Reduced mobility and/or transfer issues are predictors of incontinence. It may not be dementia causing the incontinence. Maintaining mobility is vitally important. Being constipated, a type 1 or a type 2, or having loose stools, a type 6, can cause fecal incontinence independent of dementia. Some of the common toileting cues are wandering, the person knowing that they need to do something but not sure what. Plucking at clothes, the person knowing they need to remove clothing but not recognising how to get to the toilet. Maintaining healthy bladder and bowel habits is a good first step to preventing toilet problems and incontinence. Exercise, being as mobile as possible, helps with keeping the bowels moving and getting to the toilet in a timely manner. Constipation sometimes gets overlooked. It can be painful and cause distress and confusion. Sue highlighted bowel management and constipation prevention as essential earlier this morning. Bowel management is individually different, so a focus on prior bowel habits may be very useful in planning bowel care. Allow a regular time and enough time to empty bowels. After meals, takes advantage of the gastrocolic reflex for bowels to empty, and always treat constipation if it occurs. Having enough fluid for healthy bladder habits and bowel habits requires the person to drink 6 to 8 glasses of fluid daily. Make it as easy as possible. Rather than offer to get a drink, just provide the drinks regularly, ensuring the drink is in reach and in a receptacle the person can manage. If the cup has a spout, place it towards the person. Consider reducing caffeine. It is known to cause urgency with bladder and bowel. Tailor toileting schedules to the person's own habits. Note when they use their bladder and/or bowel. How we sit on the toilet makes a difference. If using a raised toilet seat, make sure the footstool is tall enough to ensure knees are above hips. Put the footstool away afterwards to prevent falls and to be sure it's available next time. Difficult behaviour. It may be an option to change the incontinence product while a person is sitting on the toilet. The person may then assist if possible. If they see the toilet, they may recognise and help with removing clothing. Calming music, warm hands, cold hands can be frightening. Gloves prevent skin-to-skin contact, and I'm not suggesting for an instant that body fluid exposure is acceptable. Embarrassment may lead to striking out. Consider carer of same gender or a regular carer. Try not to rush. Develop personalised strategies and provide constant reassurance. Not wanting to stay seated on the toilet, you could try asking the person living with dementia to hold a doll like a baby, a football in team colours, a sensory item like chain link. You could massage the hands to help the person relax, and that provides some skin contact. Wedding photos, family photo, personalised distractions. If voiding in the cupboard, for example, you may put a stop sign on the door. We really do need to be creative, and I'm sure some of you could share some very creative examples. Strategies to improve the toileting process include colour contrasts to draw attention to the toilet, remove obstructions from the path to the toilet, and leave the door open so the toilet is visible. Check placement of mirrors. The person's reflection may look like someone else is already in the bathroom. Washable toilet seat covers are warmer and softer. Raised toilet seats and handrails make using the toilet easier. Ensure privacy, but either disable locks on the toilet door or ensure the door can be opened quickly from the outside. Simplify clothing. Buttons and zippers are difficult to manage. Be aware of language. We have lots of different ways to say we are going to use the toilet. My gran would spend a penny, use the ladies' room, the lavatory, the loo, the john, go to the bathroom. In the US, it's the restroom. Perhaps I have to pee, tinkle, take a piss, relieve myself, or nature calls. And you're probably thinking of at least another 5 to 10 terms. When introducing continence aids, it may be useful to remove regular underwear to avoid confusion. Washable absorbent underwear is generally suitable for light incontinence. It's important to try different size pads and pull-ups for absorbency and good fit, and be aware that there are more disposable products available than those on the supermarket and chemist shelf. There's also the external catheter with a condom-like sheath connected to a drainage bag, suitable for some men, especially overnight. Toileting aids can help prevent incontinence by bringing the toilet closer to the person. Assess dexterity and mobility before introducing aids. The person will need to recognise the commode, for example, be willing to use it, and find it an acceptable piece of furniture. Chair and bed pads help reduce the workload of washing bedding every day and protect furniture so people can still sit on their favourite chintz lounge. Bed pads can get heavy when wet, during washing and hanging on the line to dry, so not always appropriate if the carer has shoulder or back problems. There are a number of continence funding options. It's important to access funding schemes because continence products are expensive. They support people to participate in social activities, protect kidney health and skin, and improve quality of life. CAPS pays out every year in July, or July and January if 2 half payments are selected. A continence assessment and management plan should be completed to support the person's achieving improved continence. A range of health professionals can complete the health report in Part 3. Enable New South Wales is New South Wales state-based funding. There are 2 parts to the application: an application form which asks about income because it is means tested, and an equipment request form which details the specific continence aids required by the person. Enable New South Wales has a $100 contribution fee per year and supplies subsidised products to the person. A person may receive both CAPS and Enable New South Wales if they're assessed as eligible. They need to have moderate to severe urinary and/or fecal incontinence. And it's important to remember, if someone has had an ACAT assessment, they are ineligible for Enable New South Wales, whether they're receiving the package or not. I don't have a lot to say about NDIS. People diagnosed with dementia who are under the age of 65 and who are unable to carry out tasks of everyday life may be eligible with supporting documentation. Continence products are available under consumables, and continence assessments from private providers need to be funded in the therapies section. Private providers often do lifetime care assessments. I guess this is very much based around motor vehicle accidents, so I don't really have a lot more to say on that one. DVA are very generous to their gold card holders with continence products. I encourage people generally to seek financial support through these organisations if eligible. In conclusion, I'd like to say thank you for your time and acknowledge that your time's valuable, and to thank you for the care that you provide. Thank you. Thanks, Jenny, Kevin.
Thanks so much, Jamie. There is one question. The makeup of aged care facilities often means that people have early dinner and go to sleep early to fit in with shift works. This slows down the gastrocolic reflex. Do you have any suggestions to keep that moving?
No, not really. I guess mobility. Warm drinks can sometimes stimulate the gastrocolic reflex as well. So when people get up first thing in the morning, a warm drink as they're getting up, and then breakfast, and then often a trip to the toilet after breakfast. And again, it's all based around people's normal habits. So I guess residential aged care is a little bit difficult to know if the family carer's partner aren't able to provide some guidance there. I guess in residential aged care though, you've got the advantage of having people who can do a month-long assessment and watch for patterns and habits, and then try and develop a toileting program around what they discover.
Great, thanks for that.
Thanks very much for that, Janie. Much appreciated. Our next presentation is on exercise effects and on the functional connectivity of the hippocampus and memory. Presenting on this is Gillian Trace, a highly experienced physiotherapist and fitness professional with 37 years of experience. She's got postgraduate qualifications in health promotion, WH and S and adult education, and a master's degree in physiotherapy. She's worked closely with aged care facilities, home care organisations, and other health organisations to provide physiotherapy and exercise programming for general exercise, falls prevention for older people, and dementia-specific exercise programs. So a big welcome to Gillian.
Julian, you're on mute.
Ah, there we are. Hello. To be not muted, doesn't it? Hello, and thank you for the invitation to be able to share some things about exercise and the importance of that with regard to people with dementia and with mild cognitive impairment. It's a part of my life that I'm very passionate about, and it brings me joy, and it actually brings joy to many of my clients who have some cognitive impairment, and I've been doing a lot of sort of work in that area in the last few years. So the title of my talk seems amazingly over the top, but what I would like to do is just teach you a little bit of some anatomy, and then present to you some of the latest research around actually what's happening in terms of the whole thing around exercise and the importance in the brain and how that helps with dementia. So we're going to look first of all at a picture of the brain, just to remind ourselves a bit about that. You can see we've got varying lobes in our brain, and you can see the frontal lobe is where we do a lot of thinking, we have personality, we have reasoning. The very front part of our lobe, which is the front cortex, is actually involved in memory as well. We've got the motor cortex, where we generate movement from. We have the sensory cortex, where we receive sensory information. The parietal lobe is where we integrate that sensory information. The occipital lobe is a lot about vision. The temporal lobe is about things like hearing and speech. But deep underneath the temporal lobe, you can see there's a little picture to the one side that's called the medial temporal cortex, the lobe. And you'll see within there's a couple of little things, structures in there, which are part of the limbic system. And there's two things that are of particular importance there. One is called the hippocampus, and one is called the amygdala. And the amygdala is responsible for a lot of our emotions and setting our emotional state. And the hippocampus has been shown to be a part of our brain where we actually make memories. And we start to form those memories. The memories are not kept there. They're then shunted off to other parts of the brain, but they're formed in the hippocampus. And the back part of the hippocampus is actually where we learn a lot of spatial information, and we have a lot of spatial memory going on in that part of our brain. So we know from the research that the hippocampus is very, very important in making new memories. And the connection to right next door is the amygdala, which is where we have that emotion. And it's interesting that we have this direct connection physiologically or anatomically between memory and emotion. And I want you to hang on to that thought, because that's really important for us as we then start to talk about exercise. A couple of concepts I'd like to just introduce to you about quite recent research that's going on in this area is that we have something called cognitive reserve. And this is where we have a lot of connections building in our brain over life. And there's something called the nun study, which was research from a long time ago, decades ago, where they managed to get nuns who all lived exactly the same lives. And hundreds of them graciously donated their brains to science. So as they passed away and died, the people were able to actually take their brain and look at the amount of change in their brain related to the protein plaques that we see in dementia. And what was very interesting was that a lot of nuns actually had significant plaquing going on in their brain from dementia, but they had actually lived quite good and functional lives. And so they worked out that there's a proof, a sort of a way of protecting our brain from some of the impacts of the structural change that dementia brings. And so we talk about this cognitive reserve where we're building those connections, and the more connections we have, the greater reserve we have, even if we have, for example, a genetic predisposition for dementia. Cognitive resilience is about, again, building connections that allows us to resist some of the protein plaque formation, which causes the dementia changes. And again, the more pathways we have, the better off we will be through life. And we see that in a whole lot of different risk factor evaluations. So if we have, just recently this week on the news, if we have a stimulating and good job, that will help us. Now, why is that important? Because it's building cognitive resilience, okay? Another important concept is functional connectivity, and this is where we get lots of different parts of our brain all talking to each other in a very complex kind of way. And then the fourth thing we need to think about is what we call neuroplasticity, and this is where we actually make our nerves talk to each other in an improved way and a better way and a stimulated way. And there's a lot of quite fascinating research around how we stimulate neuroplasticity. Now you can see from some of the references there, 2019, that it's actually a new and emerging area, which is very, very exciting. And our brain is like a big switchboard. And the more we pull out switches and plug them in and change them all around, the more resilient our brain is going to be, even if we do have, for example, that genetic predisposition for something like Alzheimer's. So we can build a complicated switchboard in our brain by doing a number of different things, and exercise is an important part of that. Now, in this picture here, you can see there's little hairy, fingery bits, which are dendrites. A long bit at the end is called the axon. And what happens is, as we learn new things and develop new connections and make one part of our brain talk to another part of our brain, we are actually making the dendrites grow and develop. We are also creating new anatomical connections between one nerve and another nerve. And all of this is actually building capacity in our brain and building pathways in our brain. And that's one of the ways in which we actually develop our neuroplasticity, and we get the different parts of our brain communicating in a much more effective way. And this adaptive plasticity comes through two ways. One is what we call rerouting or rerouting, where new connections are made. So one nerve starts talking to another nerve more often and more frequently and more effectively, okay? Another part of this adaptive plasticity is what we call sprouting, where our dendrites actually grow longer, and they're sort of like tentacles that stick up and start connecting onto other nerves in a way that allows those nerves to talk to each other. And that's pretty exciting because it's actually happening in all of our brains right now if we stimulate our brains to be doing those sorts of different things. And it's happening all through life. You know, they say you can't teach an old dog new tricks. Well, yes, you can. And that's something that we need to be thinking of for a whole lot of our clients, and particularly those with early signs of dementia and those with just mild cognitive impairments. Now, if we just have a little quick overview of the benefits of exercise for those dementia, and it's interesting because even those with an Alzheimer's dementia diagnosis, we know that there's actually also some vascular component to their dementia. So we have what they call small vessel disease pathology. So it's very rare to actually have someone entirely with an Alzheimer's dementia. There's usually some vascular component to their dementia as well. And, you know, it's basic plumbing. The more your vessels are clear and clean, supplying oxygen to your body, but also to your brain, the better we're going to oxygenate in our bodies. And oxygenating your brain is going to improve your brain health. Exercise is a very effective way of cleaning out the plumbing. We also know that it's going to improve our functional strength, and that means that we can do more things. So we can attend to our activities of daily living, do the gardening, do some housework, do some hobbies, do some woodwork, whatever it is. We can do those things that bring joy to our lives more successfully if we have the strength in our arms and legs to do it. Obviously, posture and alignment is important, and I spend a lot of my time telling people to be up straight. And the more up straight we are and the better posture we have, and even in terms of our neck alignment, if your neck alignment's good, we actually get better vascularization to our brain. So the more we're getting people with better posture and alignment, the better all of our alignment is going to be. Exercise often is about social connection, okay? So we can exercise with other people, and that's going to allow us to have an, sense of fun, well-being. You don't have to go to some boot camp and be yelled at. That's not my philosophy of exercise. It's about having fun. And again, we are creating memories and emotion that is joyful. And for all of our friends who have dementia, we actually need to have a bit of joy going on in our life. And I do some exercises in an aged care facility in Armidale, and we do it in a dementia part of that aged care facility. And I put on my music and we dance and we have fun and people laugh, and it's freedom and it's fun. All of those things are incredibly important to our friends with dementia, particularly those in facilities. And I've watched some DVDs of exercise which is so boring that you would just fall asleep watching them. That is not what exercise should be, especially for our friends with dementia. And we also know that, again, that there's been some very recent studies in the last sort of 5 years that have shown that exercise actually improves hippocampal function. Therefore, because remember that hippocampus is the part of the brain where we make memories, that's going to improve your memory. So the more exercise that we do, we actually are improving hippocampal function. And part of exercise too, particularly if we do music, exercise to music, and we're using our left arm and our right arm and our left leg and our right leg, and we're doing it in all sorts of weird and wonderful ways, we're actually making all the different parts of our brain, left and right side, working in a new way that's going to actually improve that functional connection capacity across our brain. So exercise is vital. It should be an everyday part of all of our friends with dementia, those living at home and those also in residential care facilities. And it's an important part of who they are and how we bring joy to their life as well. Now, we know there's been quite a lot of studies done, and you'll see again that the dates of some of these papers are recent, in that they've looked actually at hippocampal size and the function with a whole range of different ways of looking at it. So some have looked using functional MRIs, some have looked at EEG type studies, but they've actually done quite a lot of research in the last 5 years, and they found that just exercise generally, so whether it's walking, whether it's lifting weights, whether it's doing stretching, whether it's doing dancing, all of these kind of exercise programs actually help to build hippocampal function. And they've shown that people with moderate cognitive impairment actually have an improvement in their capacity. Even more recently, they've started to look at dance, and they've started to look at how dance might have even a greater impact in people with dementia. And there's been a number of interesting studies that have shown that the complex movements that we see when we dance actually are increasing the different parts of our brains working. So and the reason why is because when we dance, we need balance, we need coordination, we need to plan the movement, like where's my foot going to be next. We need left-right side integration, and also integration across a number of neurological centres. So dancing is a whole body exercise that uses all of your brain. And they've actually shown that as the dance increases with difficulty and complexity, the more neuroplasticity actually happens, and with greater dendritic growth. So remember, the dendrites are the tendricles that join on and connect the axons. And you know, it's interesting in that it's a great way to get all of your brain working. And that's a really fantastic thing to be thinking about. And it can be done with people, obviously, like the couple that you see here are obviously quite fit and healthy and can be up on their feet dancing. But we can do it in modified ways, even in aged care facilities. You know, where we might have someone who has got good mobility will get up, put the music on, grab their hands and have a dance. And that's a very good thing for them to be doing for their brains, but also for their bodies. And it's interesting because of this sort of growth in ideas around dance as exercise, we actually know that it actually can increase hippocampal volume. And again, they've looked at this through things like functional MRIs. And they've actually shown that dancing in people actually increases cortical activity and what they call cortical synchronization, which is where different parts of the brain are talking. So if we imagine that switchboard kind of analogy is where we see that the switchboard is going overload when we're dancing. So we can see that it's this very important way of developing that neuroplasticity, developing the functional connectivity, as well as improving the hippocampus sort of state of being. And it's interesting, again, you can, oh, I'm going backwards here. Let's go on, that's it. And there's been a few quite specific studies that have looked just at dance. And one called Train the Brain Consortium, that should have an M, sorry, assessed that, that dance and cognitive training actually improved cognition and brain function and memory. And they actually suggested that we need to look at it as a holistic thing. So we don't just dance our life away, but we're doing other cognitive training as well. So we could be playing card games or doing Sudoku puzzles or, you know, bridge or whatever those sort of different things are. It doesn't really matter as long as we are trying to get people to think in new ways, in different ways, all the way through life. And the more we kind of like think laterally and problem solve, as well as move our body, is going to actually improve our brain, our memory, and our cognitive function. Another study here, Mueller, used again a functional MRI to compare dance with just other kinds of exercise. And they found that those that were dancers had an increased parahippocampus volume, so the size of the hippocampus improved, but also that there was an increase in memory function even after 18 months. So there's not just a short-term thing, but there's actually a long-term thing over time that improves that memory function. Another study actually looked at, again, a dance program, and they found that the dance group had improved cognitive function, and they actually, again, looked at the frontal temporal and the hippocampus cortex, and they found, again, that there'd been improvement there in anatomical change, but also in terms of memory change. And then another study in 2019, they looked at a dance movement intervention, and it was over a 6-month period with people taking 60 dance lessons. And this study also showed that that dance group had a significant improvement in their cognitive testing. So we can see that dance is quite a particular thing to help with just getting the, you know, the whole brain working. And there's been a few different studies to say, well, how much, what's the dose, how often should we do it? And it's a mixed bag here of research, but it's interesting that they find that mild to moderate intensity, so 50 to 70% of your maximal cardiac output, and that's a bumpy thing to do with your heart rate. But even up to vigorous levels of 75% of your maximal cardiac output had good benefits for your brain and your cognitive function. And then another lot of studies have actually looked to say how often, and they actually say we should be doing it about 5 times a week for about 30 to 40 minutes at a moderate level. So if we think about how much am I personally exercising, how much are you personally exercising, we need to actually be adding exercise as a therapy tool for a lot of people in our lives, particularly those that we know who do have those Alzheimer dementia genes. Those with that mild cognitive impairment, we need to really be pushing the exercise, and we just need to be also just making sure that we are encouraging people to move as much as they can within those guidelines. So that's all I wanted to share with you today. I guess it's just a bit of a roundup of what's happening in the current research in exercise and dementia. It's a very evolving area, it's a very exciting area, and it's a very fun area because we can all have fun as we exercise. So that's what I'd like to share with you today. Over and out.
Thanks so much. There's no questions at this stage, but if any come up, I will let you know.
Okay, thank you.
Thanks very much, Gillian, and comments coming through. A great presentation. I'm glad we all survived the little sound out for a few seconds. I think everyone was impacted by that. I was certainly looking at my screen, but it should be all back for everyone now. So hopefully that is happening. Our final presenter and presenting on nutrition and dementia is Dr. Amy Ashman, an accredited practicing dietitian working as a primary care dietitian at Healthwise in Armidale. And as part of her role, she frequently visits aged care facilities and works alongside care staff to help clients, including those with dementia, to optimise their dietary intake and nutrition status. Amy completed her Bachelor of Nutrition at the University of Newcastle in 2012 and went on with further studies at the University of Newcastle and received her PhD in nutrition and dietetics in 2017. So welcome to the forum, Amy.
Thanks, Kevin, for that lovely introduction, and thanks everyone. Can you see my screen all right?
Yes, no problem at all.
Okay, lovely, thank you. Beautiful. Thanks very much for asking me to present today. So I'd like to start by acknowledging the traditional custodians and caretakers on all the lands on which we are meeting today. I would like to pay my respects to elders past, present and emerging, and to the future leaders of tomorrow. I'm just sharing my webcam there. All right. So I'm just going to give a brief overview today about the topic of nutrition and dementia. We'll be talking about why nutrition is important in dementia, some of the nutrition recommendations for older adults in general, and recommendations from clinical practice guidelines on nutrition and dementia, and some tips for managing some common nutrition issues in people with dementia. So why is nutrition such an important consideration? So optimal nutrition is important for all of us for health and quality of life. It helps us to recover from illness and injury and helps protect against sickness. But for people with dementia, they can be at particular risk for malnutrition. The prevalence of malnutrition is higher in cognitively impaired individuals, and malnutrition is associated with cognitive decline as well. So several factors contributing to this greater risk of malnutrition, including loss of appetite, which can commonly occur. Conversely, insatiable appetite can also be seen, and cravings for sweet foods. Some people may have increased energy requirements due to pacing or agitation. Some people may forget meal times or forget that they have already eaten and eat again. As the disease progresses, people may have difficulties with shopping for food, with storing food and preparing and cooking. Dysphagia may occur, as we've heard about earlier on in today's forum, and dry mouth and mouth discomforts, which makes it uncomfortable and difficult to eat. People may have an inability to recognize food and drink for what it is, and may forget how to use eating utensils as well. Some people may spoil meals by adding too much salt or pepper or sauces in an attempt to make the food tasty. But of course, if we add too much of those things, it becomes impalatable. And some individuals may spit out food or pocket food in their cheeks or hold food in their mouth. And individuals with dementia may have difficulty finishing their meals due to becoming fatigued or becoming distracted or agitated. And some people may not recognize new foods that are not familiar to them, or foods that may not be part of their traditional food culture. So in addition to these dementia specific issues, people may be affected by age-related impairment, like difficulty with chewing and dentition, or difficulty with dexterity. And so that can further contribute to the risk of malnutrition. So energy and nutrient requirements for people with dementia are similar to other people their age. Some people with dementia will have increased physical activity due to restlessness or pacing, and therefore increased energy requirements, but some people may be more immobile than usual. There's no specific dietary pattern for cognitive function in people with dementia, and the recommendations for other adults their age should be followed. So the Australian dietary guidelines for adults recommend eating a wide variety of nutritious foods from our core food groups, as illustrated here in the Australian Guide to Healthy Eating. And those are grain and cereal foods, vegetables, fruit, calcium-rich dairy foods and other calcium-rich alternatives, and lean protein foods. And the guidelines recommend keeping physically active in order to maintain muscle strength and a healthy weight, and to limit intake of foods which are very high in saturated fat or added salt or sugars, and to limit alcohol. So I just wanted to talk to you today about the ESPEN guidelines for nutrition in dementia. These were published in 2015 and lay out 26 recommendations for nutrition in people with dementia. I'm not going to talk about all 26 today, don't worry, but I've just selected a few and sort of grouped them together. So firstly, they recommend screening for malnutrition and close monitoring of body weight in every person with dementia. So people with dementia more often have a history of weight loss compared with cognitively healthy people, and this becomes more common with disease progression. The mechanisms of weight loss in dementia are complex and multifactorial and not fully understood. And people with dementia, there's documented associations between weight loss and increased mortality risk in patients with dementia, and some evidence to suggest that low BMI is associated with reduced survival. So why is the loss of body weight an issue? Because it can imply a loss of muscle mass and subsequent functional decline, frailty, loss of independence, and increased risk of morbidity and mortality. So there's a number of tools for screening of malnutrition. One which is commonly used is the Mini Nutritional Assessment short form tool. And this is validated in populations in older adults and is used for people with and without dementia. So screening should occur at the time of diagnosis, screening for malnutrition at the time of diagnosis, and at regular intervals thereafter, alongside regular monitoring of weight. So there's sort of insufficient evidence to say exactly how frequently this malnutrition should be monitored. But for somebody in a community setting, you'd be wanting to do this every 3 or 6 months or so, but certainly more often if there's any change to dietary intake or health, or in periods of acute illness. And likewise with weight, every 3 months or so, but certainly more often if people change their eating habits or lose weight or become unwell. And so if somebody is screened and found to be malnourished or at risk of malnutrition, that person should have individual assessment and appropriate nutrition interventions in place by a dietitian. So the SVN guidelines recommend providing adequate, attractive food in a pleasant environment, provision of adequate nursing support, and elimination of potential causes of malnutrition. So sufficient quantities of energy and nutrients, of course, should be provided that can meet a person's energy and nutrient requirements. And consider personal likes and dislikes, and remembering that these can change over time. Consider sensory characteristics of food, which is going to make it more appealing. So things like the look of the food, the taste, of course, and the smell, and making food as attractive and appealing as possible. Provide snacks. It can be difficult to meet all energy and nutrient requirements on only 3 main meals a day. So snacks can really help to improve dietary intake. And finger foods can be very helpful as well, and we'll talk about those a little bit later. And avoid restrictive diets, diets that are very low in fat or sugar, low fat diets, low salt diets, because this can impact on the taste of the food, of course, and therefore the enjoyment of the meal. So consider also the ambience of the meal times when working with carers, or if you're in an aged care facility, or advising your patients and carers of patients. So factors such as eating in company can help improve dietary intake. Also things like use of tablecloths and napkins, family style dining, rituals around meal times, particularly this is something that was important to the person throughout their life. So things like saying grace before a meal, as that can help to make the meal more pleasant for that person, as can things like pleasant lighting, nice music, just anything which is going to make the meal experience an enjoyable one. With progression of the disease, food intake should be supervised. Eating should be encouraged and supported by relatives or carers and nursing staff. And people may need assistance with shopping and cooking and eating. And intervening in areas of potential cause of malnutrition is really important because obviously we want to prevent malnutrition as much as possible. So things like if there's any issues with chewing or swallowing or mobility, psychiatric disorders, times of acute disease, or any social problems, and putting in place the appropriate health professionals and interventions or social support before these issues lead to malnutrition and become a larger issue. And the SVN guidelines do not recommend the use of single nutrient supplements, so things like vitamin and mineral supplements, unless, of course, there is a sign of deficiency, and then these are warranted. Oral nutrition supplements, however, are recommended to improve nutritional status where there is insufficient oral intake from normal food. So if somebody is struggling to meet their energy or nutrient needs on food alone, an oral nutrition supplement can be helpful. However, there's no evidence to suggest they're used to correct cognitive impairment or prevent cognitive decline. Artificial nutrition, so like enteral tube feeding or parenteral nutrition, is suggested for a limited period of time to overcome a crisis situation, and only if oral intake is markedly low, and if that low intake is caused by something that could potentially be reversed. So it's not for patients with severe dementia or in the terminal phases of life, because it is an invasive intervention. So it's always about that weighing up the potential complications with the potential benefits of improving nutrition. And so that's got to be done on a case-by-case basis, of course. Okay, so some tips around some common nutrition issues. So sometimes people may forget to eat. So what can help is setting reminders for meal times. That can be an alarm clock or an alert on someone's mobile phone. If a person is living independently, having phone calls around meal times to remind them to eat. Having visual cues, so for example, leaving snacks out in a space where they can be easily seen, like on the kitchen counter. Things that don't need to be refrigerated, like crackers or muesli bars or pikelets, fruit, dried fruit, those sorts of things. People may find it difficult to prepare meals. So really make use of those meal delivery services, things like Meals on Wheels or delivery from local restaurants. And that can be particularly nice if somebody had a favorite restaurant that they went to regularly, and then they can still eat that food and have it delivered at home, and that saves preparing a meal. Or those pre-prepared meals from the supermarket, you know, the frozen meals, they can be nutritious. Meals can be shared occasions where possible, involving families, carers, and the person with dementia cooking together and sharing a meal, and this offers a good opportunity to model eating. Cooking large amounts of food at one time and freezing portions can be another good time-saving tip. And of course, at some stage during the disease progression, home support may be needed to help with things like cooking, preparing meals, and eating. And keeping snacks on hand as well that don't require cooking or preparation, that can be easily grabbed and eaten. So fruit, tubs of yogurt or custard, cheese and crackers, toast with toppings. Finger food can really help with if people are having difficulty actually eating the food. So some ideas for finger food include sandwiches with fillings that don't easily fall out, sausage rolls, quiches, fritters, muffins, pikelets, soft muesli bars, crumpets, vegetable wedges, cooked vegetable wedges, ice cream cones, Tetra packs of milk. And these things can be really helpful for people that are walking around a fair bit, something that they can grab on the go, but it also helps with independence because they're easier to eat and don't require any utensils to eat. And avoid anything that could be a potential choking risk, like tough, crunchy, sticky or overly dry foods. Try not to overcomplicate. Oh, we talked about keeping food in an easily accessible and visible place. We mentioned that. Don't overcomplicate table settings with lots of cutlery or crockery. Even pattern crockery may be confusing. And try to just serve one course at a time. And make it as easy as possible for the person by removing excess packaging, lids, that sort of thing. It can be helpful to eat together for carers to eat with the person with dementia. This is a really good opportunity to model eating. And as we discussed, the social aspect of eating can increase dietary intake and allow plenty of time to eat meals. Some people may need an hour or even more to eat their meals. And provide plenty of support, encouragement, praise, and reminders to the person to help them to eat their meals. Any difficulty with swallowing, of course, should be assessed by a speech pathologist, and Lynn covered this nicely in her session. And also that regular assessment of their swallow is important too, because you don't want anyone to be on an unnecessarily on a textured diet if they don't need to be, because it does impact with the enjoyment of a meal. All right, if people are having loss of appetite, small frequent meals can help, but really ensuring that every bit of the food eaten is really packed with nutrition, protein rich and calorie dense. So like snacks like enriched milk, so milk made with some milk powder, cheese, yogurt, custard, smoothies, fruit cake and fruit bread, really dense stuff, sandwiches, pancakes, cream-based soups, baked beans, like really energy-dense food, so that every mouthful is packed with nutrients, basically. Talk about favourite foods that the person enjoyed, and remember that food preferences change over time. You can ask relatives what that person used to enjoy when they were younger, and maybe consider foods that are important for them culturally and that they might have had in their past. Offer familiar foods as new foods may not be as readily accepted. Have the biggest meal at the hungriest time of day, and accommodate unusual food requests, so things like dessert for breakfast time, or whenever they want to have one of their favourite foods, that can be accommodated. And we mentioned before, making use of mid-meal snacks because it is difficult to meet all requirements on just 3 meals a day. Eating with others, we talked about. Keeping food and snacks in an easily accessible place, we talked about. Ensure food is filled with flavour. Make good use of things like herbs and spices. Lemon juice and pickles can add a nice sour taste, or mayonnaise, a rich taste. Sauces, anything that's going to improve make the food more appetizing and enjoyable. And offer fluids separately from food where possible, just to maintain appetite, but do ensure adequate fluid intake, as Janie talked about. Obviously, that's very important. If somebody's really got a small appetite, try and encourage them to at least eat the protein part of the meal first, because then you know that they've had that sort of most nutritious part of the meal when appetite is at its greatest. So that's the red meat or the chicken or fish or eggs or beans, that part of the meal. And if a person is losing weight or their dietary intake is declining, do refer to a dietitian. References. That's it from me. Thank you very much.
Thanks, Amy. There's been lots of positive comments coming in about what a very intuitive talk that was. So thank you very much, but we don't have any questions.
No problem. Thank you so much.
Thank you very much, Amy, to round out the day in such an informative fashion. And to everyone, I know with these types of things, it can be hard to run to time, but we're only 3 minutes over time. So look, thank you very much for your attendance and participation, as well as all the presenters. And while we are unable to meet face-to-face, today's forum, I think, has shown that even in this virtual environment, we can still have an event that has a high level of interaction, audience participation, expert insight, and also information sharing. So I do hope you've enjoyed attending today as much as I have emceeing it. Now, I was going to offer a prize for anyone who could recite the words to the Sesame Street track, but I couldn't really find anything remotely appropriate amongst the bric-a-brac as a prize on my office's shelves, so apologies for that. But speaking of cooperation, it takes many hands to get events like this off the ground, and congratulations to all those who helped coordinate today's forum. Thanks again for your participation. I'll now hand over to Jenny Pearson for the closing remarks.
Thank you so much, Kevin. It's been wonderful to have you emceeing today. Thanks everyone that's attended, and a big thank you to the presenters who've given up their time. And I'd really like to thank the committee who have organised this forum. It has certainly worked very well. Just before you go, just a reminder, there's an evaluation that will pop up at the end. If you could please fill it in, it only takes 30 seconds, and a copy of the webinar and the presentations will be on our website, and you'll get an email tomorrow with the certificate attached and the web address where you can have a look at our education library, where we will have the presentations and the webinar. Well, thank you everybody, and I'll see you next time.